Hello.
No. Okay. I can hear something now.
Hello.
Hello, I can hear now.
Hello.
Hello, I can hear now at my end.
Okay, good morning.
Good morning, sir.
Good morning.
Good morning, sir.
Good morning, sir.
Good morning, sir.
Good morning, sir.
Good morning.
The video is not showing. Hello, good morning, everyone.
Good morning.
Good morning, sir.
Morning.
Hello, please.
Hello, good morning.
Hello, sir. You can start.
Okay. Sorry, excuse me. Let me. Sure. Good morning, everyone.
Good morning, sir.
I must say that I'm very delighted to be with our happy family this morning. And I want to thank the Almighty God who has preserved each and every one of us to be able to participate in the seminar of today. And I must also appreciate the management of the Ray Medical Rehabilitation Institute for the privilege given me to anchor the program of today. I do not take it for granted. I am sincerely grateful. And I want to also appreciate each and every one of us that is joining for the presentations of today. I hope, I desire that it will be a refreshing time for each and every one of us, that it will be informative and it will have positive impact, on our individual practices for the benefit of the wonderful clients that trust in us to intervene in their health situations. Today, as I welcome us, I know that the organizers must also have done a welcome, maybe during the time that some of us could not really hear what was being said, but I know they will have welcomed us. So I join my voice with the organizers. And like we have been communicated, we are looking at the subject, principles of assessment and rehabilitation of cardiopulmonary conditions. Principles of assessment and rehabilitation of cardiopulmonary conditions. Before I move on, permit me to say something on this topic and therefore the direction in which the presentation will go. This topic is principles of, and not particularly assessment and rehabilitation. And the good thing about it is that once principles are well known, practice will definitely be at a cutting edge. More so, if it were to be assessment and rehabilitation, it would have been better handled as a practical workshop. But being a seminar, we are going to dwell more on the principles that undergird what we do, why we do what we do, as scientists, being able to explain why we are doing what we are doing and what we expect as a result of what we are doing. So, and each and every one of us, we are already professionals. And so there are certain assumptions in terms of the fact that there are things we already know, and we don't need to begin to go and belabor again. Now, I've broken this major subject heading into some chewable bits so that we can take them one after the other and go through. What I'm presently doing is a kind of introduction. And then after the brief introduction, I'm going to go into the first topic, which is problem-oriented approach in the management of patients with cardiorespiratory condition. And of course, the problem-oriented approach is a principle, is a method, is a school of thought in terms of the approach. And so we'll be looking at why should we prefer a problem-oriented approach in the cardiorespiratory specialty, even though other specialty areas in physiotherapy may use it, but a good number of times they use other models. But in particular for cardiorespiratory specialty area, a good number of the models that are used in the other specialty areas will not permit a cutting-edge practice in cardiorespiratory specialty. Because a good number of times, especially when we have to handle critical care and acute care, we don't have the luxury of time. Take, for example, under clinical reasoning, we know that the basic reasoning technique is the hypothetical deductive model. But in cardiorespiratory, if you try to venture into hypothetical deductive model, you might lose your patient before you start testing all your hypotheses. So pattern recognition will be a better approach when we talk about clinical reasoning in cardiorespiratory specialty area. And, looking at that as a typical example, that's why we advocate for problem-oriented approach in cardiorespiratory practice. Now, the next topic I will handle is physical diagnosis in cardiorespiratory physiotherapy. Most of the time, patients will be referred to us with medical diagnosis. And a good number of times in the health sector, it is thought that it is only physicians that diagnose, but rather physiotherapists are trained to diagnose. The fact is that we practice physical diagnosis rather than laboratory or whatever other type of diagnosis. And then the topic that will follow that is identification of problems that patients are presenting with. How do we identify the patient's problem? A problem identified is a problem half solved. When the patient's problem is not accurately identified, there will be a lot of beating about the bush. And time is of essence in cardiorespiratory practice. When we then identify the problem, how do we set our goals? How do we make sure that there is what is referred to as constructive alignment in teaching methods? How do we ensure constructive alignment in terms of the goals that we set in our patient care? And then I will move on to principles of management and outcome assessment. So when we now want to manage, we want to treat, we want to take care of the patient, what are the principles that guide what we do? And then how do we assess the efficacy of our intervention. Before we now move on to various types of physiotherapy intervention, and therefore the principle that guides the utilization of each type of intervention. And of course, we'll then move on to look at cardiac rehabilitation as well as pulmonary rehabilitation. I'll talk about pulmonary rehabilitation because a good number of times, cardiac rehabilitation is more popular than pulmonary rehabilitation. So those are the topics we are going to handle in the seminar of today. And then I have a kind of schedule trying to, manage the time so that we can cover all that we intend to cover. However, we are starting somehow behind schedule. I think this is already 10:29. And according to the schedule that I had, the first lecture was supposed to kick off by 10 o'clock after the initial welcome and introduction. And so that means we are about half an hour behind schedule. So we'll see how we shorten some of the presentations in order to fall back in line with the timing as stated in the schedule. Now, just like I've mentioned, the focus of this workshop is talking about, principle of assessment, principle of management, principle of rehabilitation, laying emphasis on outcome-based practice, and the employment of evidence-based practice, as well as, laying emphasis on patient-centered practices, because no two patients are exactly the same. So most of the time we need to customize the line of management for individual patients. So that's the focus that we'll try to maintain in this presentation today. So you are welcome on board. Without further ado, I move on to the first topic, which is problem-oriented approach in the management of patients with cardiorespiratory conditions. In managing patients, there are diverse approaches that can be employed. But I am an advocate of the problem-oriented approach. Now, this is the scenario, a kind of justification for what I advocate for. When patients come to the clinic, most of the time, they present with a seemingly formless combination of complaints and physical findings, because they are not scientists, they are not healthcare people, so they are not familiar with some of the medical jargons or physiotherapy jargons that we speak as professionals. All they know is that they have complaints that are serious enough to have prompted them to desire professional intervention. Rather than coming based on a previously diagnosed disease. They are not even familiar with your terminologies of diagnosis. When the patient now gets to the clinic, it is important that the therapist, in this case now, assesses the symptoms and signs that the patient is complaining of. And through such assessment and analysis, identify specific problems that the patient is having. And then the therapist will systematically, restore, those functionalities and resolve the problems. Therefore, what the therapist is handling is the patient's problem and not necessarily the medical diagnosis. When we look at a lot of textbooks, most of them are still organized in terms of the chapters, how they arrange the chapters of the books based on pathophysiologic concepts or maybe specific disease entities, whereby you pick a textbook on cardiorespiratory disorders and it says chapter 1 is COPD, chapter 2 is cystic fibrosis, chapter 3 is pulmonary tuberculosis, and then they treat condition by condition, specific disease entities. But you discover that within each specific entity, there are challenges that the patient suffering from that condition will have. So when we want to handle the patient, we are not trying to destroy or eliminate pulmonary tuberculosis. But the challenges that condition called pulmonary tuberculosis is imposing on the patient, we want to relieve the patient of the distress or whatever discomfort he is having as a result of the tuberculosis. So if it is productive cough, for example, we want to address the productive cough. Our focus is not on pulmonary tuberculosis, but on whatever challenges the patient is having. So, attempts to emphasize the recognition and the definition of specific clinical problems, and therefore teach, how to approach the resolution of those problems are still very few in textbooks. And so it happens that as people train and as they graduate, because it is these so-called textbooks that they use as their resources, they continue to be aligned towards the pathophysiologic model and concept. And with that, the quality of care remains compromised. According to Lawrence Weed, there are certain components that are common to all healthcare approaches. And he originally identified them in a problem-oriented fashion. And there has been a lot of description, and he has propounded a number of methods. There was the issue of the problem-oriented medical record keeping, POMR, which was the first step before he now came out with the problem-oriented approach to treatment, POAT. And these phases of medical action that he identified are charted, on this slide. And we can see the 4 phases. The first part is the database. And that's talking about all the information that you try to gather by every means possible. Then, how you analyze all those information to come up with a clinical impression and say, this is what is wrong with this patient. This is the challenge this patient is having. This is the problem being faced by the patient. The clinical impression. Then there is the sitting down to decide, how do I want to approach this patient's challenge? How do I want to help the patient out? How do I want to resolve this problem? And that's talking about the plan that you make, the written plan. And under the written plan, there are various components. There's the diagnostic plan. What am I going to do to further narrow down the identification of the challenge, as to be very sharp and be able to hit the nail on the head when I begin to take care. There's the treatment plan. What do I intend to do? What do I intend to give? How do I intend to carry it out? And then there's the education plan. A good number of times, some of the challenges that the patients have can be preventable. And if the patient initially knew, he probably might not be in the situation that has brought him to the clinic. Therefore, in order to forestall recurrence, there's the need to educate the patient about that condition, even the etiological factors or the risk factors, so that by avoiding the risk factors, he can prevent recurrence. Or even it can be in terms of what we are doing for the patient, to educate the patient to understand the importance of what we are doing. It is when they understand the importance of what we are doing that, especially if there is a home program aspect of it, they are more likely to adhere to the home program and therefore improve the outcome. The education might even be for secondary prevention. In other words, to slow down the progression of the condition, or to avoid complications, or to slow down the rate of deterioration when it cannot be totally stopped. So in all this, the patient needs to be properly educated, provided with information that can modify his behavior. And then there is the aspect of the case progress. As you continue to treat, what problems get resolved? What problems proves difficult to resolve? What new problems even surface while you are trying to manage one? So these are the 4 common components of case management, no matter the condition, no matter the specialty area. So I spoke about the POMR as propounded by Lawrence Weed. He opined and proposed, and it had been followed for decades now, that the patient information should be presented in a structured manner. So when we talk about the problem-oriented medical record keeping, we are talking about a structured organization of the patient's information as it relates to specific problems that the patient has. And, it is meant to aid the clinician to deal decisively, with the multiple, problems that the patient may be presenting with. Now, on the record, we have data about the health status of the patient. And, according to Lawrence Weed, it should be arranged in a problem-solving system It should be arranged in a way that is easily accessible. And it should be arranged in a way that encourages ongoing assessment, as well as, the structured healthcare plan by every stakeholder. And so, especially those of us in cardiorespiratory specialty, the way we record in the patient's case note or in the physiotherapy card is very, very important. We shouldn't write as if we are writing shorthand. Our records should be explicit and sufficiently detailed, as for others to be able to easily understand what we are doing and be able to take over management if necessary. Then we have the issue of the observations, the assessment, and the healthcare plans, based on the patient's problem. Now, in the problem-oriented approach that Lawrence Weed, proposed, there are 3 main strands. You have, the problem list. And the problem list contains, different types of problems, both the active and inactive problems that are amenable to physiotherapy, the medical problems. For example, a patient with pulmonary tuberculosis, that's the medical diagnosis, that's the medical problem that the physician has identified. But he is not sending that patient for physiotherapy because the patient has pulmonary tuberculosis. But rather, that patient that has pulmonary tuberculosis is now having chest pain, is having productive cough. The productive cough that is having is copious, or might even be difficult to expectorate. So it is those problems that make the physician to refer the patient for physiotherapy. So when we are talking about active and inactive problems, we are talking about those things that physiotherapy can intervene and resolve. But the medical problem is the pulmonary tuberculosis. And human beings are psychosocial. We are social creatures. And so a good number of times, with the physical ailments that people have, there are other social problems. Take, for example, that same case of the patient with pulmonary tuberculosis. We know that one of the risk factors for pulmonary tuberculosis is low socioeconomic status. Because with the low socioeconomic status, their nutrition will be compromised. In terms of accommodation, they are more likely to live in a crowded place. They are more likely to be exposed to poor hygiene. And they are more likely to contact cross-infection because of the crowded environment where they exist. So the poverty is a social problem and should also be highlighted. Now, the second strand is the background information. And the background information or the database contains both fixed information as well as changing information. Fixed information is talking about information about the patient that remains constant no matter when, that cannot change. For example, if a patient is a female, she remains a female. Don't mind the LGBTQ people or whatever. They are just fooling themselves. A female is a female. A male is a male. Date of birth cannot change because you cannot be born, twice. Immunity status, if, remains. But we can have changing information like marriage. Somebody who is not married today can be married tomorrow. A married person can become a divorcee or a widow or a widower. Job, employment may change. Address may change. Those are changing information. So the database contains all those information. And then we have the third strand, which is the progress notes. And that's talking about things that you assess from the patient, either subjectively or objectively. The plans we make for the patient, the goals we want to achieve, the actions we undertake, the counsel or the education that we give the patient. That constitutes the third strand. And usually that is presented in a SOAP format. I don't need to belabor the SOAP format. We are all professionals. And so this approach is designed to improve the structure of the record. It is designed to encourage a logical thought process. And it is designed to generate less narrative, but clearer records that can allow for effective communication, either about the patient to the patient himself or herself, or about the patient to other clinical professional that is involved in the multidisciplinary care of the patient. The problem-oriented approach to diagnosis and treatment, is an extension of the record keeping that was originally introduced, like I said. And so it has been shown to be a rational method to manage clinical cases. And at the center of this approach is the problem. And that problem dictates the goal. And so a good number of times, it is said that the problem becomes the goal, because the goal is the resolution of that problem. And it therefore dictates the medical path that has to be followed. So, for example, if a patient has the problem of inability to individually or independently expectorate, then our goal will be for that patient to become capable of expectorating the mucus himself or herself. Now, this approach is embarked upon step by step. And the step one is to create a defined database of the patient's problem. The second step is to formulate a problem list. When we say a problem list, it does not necessarily mean that there must be 10 issues on the list. But no problem of the patient should be overlooked. So it's possible to prepare a problem list of a patient and it is only one problem that is there. And it is possible for a particular patient to have up to 5 items on the problem list. The important thing is that there is nothing that gives the patient concern or that bothers the patient that is left out and not listed, so that it can be addressed. So when we therefore talk about problem, what do we identify to be a problem? Anything going on with that patient that does, or that is capable of requiring healthcare management, or that has significantly affected the patient's well-being, or that could significantly affect his health or well-being, that is a problem. Another description of a problem is anything that causes concern to the patient or to the caregiver. Not only physically, but even psychological disturbance and socioeconomic problems. They are problems and they must be listed. And like I said earlier on, problems could either be active or inactive. When the problem is present in that patient and the patient is complaining of it, that is an active problem. But when there is a problem with a patient and that problem had been resolved, but it is important that because that problem had occurred before, it should be kept in view concerning that patient. Then that is an inactive problem. Let's look at this scenario, for example. A patient, had suffered a loss that has impacted on him or her socially and psychologically, maybe bereaved of a beloved one. Now, that had happened, is now over 2 years or 3 years. In quote, he has gotten over it. Sorry, just a moment. My power supply here had gone off. I want to quickly connect to another source of power. So please just spare me 2 minutes to change my power source so that things don't just go off suddenly. Yes, thank you. I've changed the power source. So I'm back. So I was talking about a problem that is inactive. Now, the patient now has another problem that has brought him or her to the clinic. Somehow, even though the bereavement can be said to be in the past, there is a way it is capable of influencing or affecting the patient while undergoing treatment for the present active problem. So even though that problem is no longer active, it should be kept in view in managing the patient. Now, the master problem list should therefore include the active problem, inactive problem, temporary problem, potential problem. Potential problem is talking about a possible consequence of what the patient is already having, even though it has not developed. And that is being proactive or preemptive. You don't wait for it to occur before you now begin to take cognizance of it. You take cognizance of it even before it happens, so that you could possibly even avert it from happening at all. When we therefore have such a list, it serves as an index to the rest of the record. And according to the POMR, the record keeping, there's a way that it's supposed to be organized. But today, our emphasis is not on the record, but on the approach to treatment. So I'm not going to dwell so much on this, Now, on that record, problems can be added, it can be removed as they get resolved and as new ones come up. Remember, each problem that is identified is actually a conclusion or a decision resulting from certain things that have been carried out in terms of the examination, in terms of the investigation, and in terms of the analysis of the information that is before the therapist. Now, the data is important for the setting of goals. It is important for planning for diagnosis and management. And so, how do we formulate the problem that a patient is presenting with? Because, the quality of our plan depends on how complete and how precise we have been in identifying and defining the problem. And all of the problems must be listed, both past and present. It could be social, it could be psychiatric, it could be medical. I've made mention of a social problem that is in the past, for example, a bereavement. And in writing a good plan to resolve a problem, you cannot, do it effectively if you don't know all the other problems. Because there are some other problems that can influence your plan. Let me just give us an illustration. As physiotherapists, we are familiar with the issue of contraindications and things like that. Somebody has a problem in the knee joint, pain. Ideally, to resolve the pain, you are deciding to give shortwave diathermy to address it. That's your plan. But this patient has had another problem in the past, which is now an inactive problem. Based on that problem, there was a surgical procedure that was done where a metal implant had been placed around that place. Now, if you are not aware of the presence of that metal implant and you had felt free to go ahead to make plan that, okay, to address the pain in the knee joint, I will use shortwave diathermy and everything. Now, you can cause a very serious problem for the patient because you are unaware of another silent or inactive problem in that patient when you are making or formulating your plan. Whereas, if you know of this other problem, though inactive, there is a way it influences your plan. That pain is there. You could have used shortwave diathermy, but because of your consciousness that this other problem exists, you will say that application of shortwave diathermy is contraindicated in this case. Therefore, I have to do something else. So that's how important it is for us when we are setting our goals or when we are writing our plans to be aware, to know the other problems that the patient has. Otherwise, our intervention may be counterproductive. Its effectiveness can be compromised. Now, in coming up with these problems, it can come in various ways. There are situations where a medical problem may be a diagnosis. Take, for example, if a patient is having headache. Headache is a diagnosis. But the fact that the head is aching him, that's the problem he is having. So in that instance, the headache, which is a diagnosis, is also a problem and can be listed as a problem. But let's look at a patient with chronic bronchitis. He has productive cough. He has chest pain. He suffers breathlessness. The medical diagnosis is chronic bronchitis. But that patient's problem is not chronic bronchitis. Rather, the problem list for that patient will be chronic productive cough, dyspnea, chest pain. Because in writing your plan, you are now going to plan how to resolve the chest pain. You are going to plan how to, deal with the sputum production. You are going to write how you are going to deal with the chest pain. That's what is going to be included in your plan. You are not going to talk about chronic bronchitis. That's a medical diagnosis. That's not the patient's problem. So the problem can be a physiological finding. The problem can be a symptom. The problem can be a physical or laboratory finding. For example, a physical, problem, inability to bend and assume the prayer positions as a practicing Muslim. That's a physical finding, and it is the problem of the patient. The patient is bothered because he can't join others to observe the prayer times. And like I said, every problem in every aspect of the patient's being must be defined as precisely as possible. It could be marital problem, it could be financial problem like bankruptcy or whatever. It must be listed. And from time to time, the problem list must be updated because some problems will become inactive and some problems that were not there before will rear up their heads. Let me skip this one. Now, some of the problems can be more serious than others. And you need to identify them and categorize them because you are going to need such categorization in prioritizing. You know, some problems could be minor, self-limiting, or temporary. Some might be minor problems that resolve and, could recur. So you've got to know and pay attention to problems that are more severe, that are more troublesome, and that have, known or identified solution. Now, in cardiorespiratory specialty, we have some problems that are common to either the cardiovascular system or the respiratory system. You have some problems that are peculiar to the respiratory system. You have some problems that are peculiar to the cardiovascular system. But what I've tried to do here is to list problems that are commonly found or that we commonly come across when patients present with specific disorders, either respiratory or cardiovascular. So on this slide, we have common problems in respiratory disorders. Pain, especially in the chest, reduced lung volumes, altered chest mechanics, ventilation perfusion imbalance, reduced clearing mechanism for the mucus, secretion, congestion, reduced mobility, reduced exercise tolerance, anxiety. These are common problems you come across in patients having respiratory disorders. And in dealing, with the problem, you write out the goal. Your goal must target that problem. And in writing the goal, attention must be paid to the context. In other words, what are other surrounding issues? Because when you want to plan for a particular problem, the presence of another problem can preclude that plan. Because that comorbidity may render your, a planned line of intervention not practicable. And when distraction with the phone, I didn't remember to put it in silence before we started. So I better use the opportunity to put it in silence now. Okay. So I can In problem-oriented approach, we have some terminologies, that we come across, the basis, that's talking about the evidence that justify the level of decision that we are making, how we are drawing inference about the problem. That's talking about the degree to ability to perform stable or stagnant or stationary. Is it improving? In other words, the problem is resolving, or is there deterioration whereby the problem is getting worse? So that's status of the problem. Then the goal. What's our goal that we are setting for that patient? Treatment goal. And goals must be stated in a smart format. We are professionals. We remember, what SMART represents: specific, measurable, achievable, realistic, or relevant, and then time-based. Now, plan formulation. When we now want to set our plan of action, there are two dimensions of the plan, diagnostic plan. Maybe we are trying to further narrow down the patient's problem. We want to do more investigation. That's a diagnostic plan. What do we want to do to further clarify the challenge that the patient is having? The therapeutic plan. What do we want to do to resolve the patient's problem? So, all these plans must be clearly stated. And that's the third step in the problem-oriented approach to treatment. We get database, we analyze and identify the problem, and then we formulate our plans. So this is just talking about the diagnostic plan. It is to verify the problem or to localize the problem, while we have the follow-up as the step 4 of the problem-oriented approach. In other words, having formulated our plan to resolve it, when we begin to intervene, there must be a re-evaluation to see, is the patient improving? Is he getting better or not? So, as we do this follow-up assessment or review, we can come up with prognostic consideration to say, this patient is going to recover. This is how much recovery this patient is likely to have, in this area of problem. And then it can also guide us as to the kind of education that we want to give to the patient. The follow-up, we say it should be in a kind of narrative note. It should also be in the SOAP format: subjective, objective, and then the plan, assessment, and then analysis, and the plan of treatment. Then, one other thing that is very important that we must mention here is that a good number of times in physiotherapy practice, we tend not to get patients to the point of discharge. because follow outcome-based Oh, my microphone was even muted. Sorry. Did you people hear what I just said? Hello?
No,
We
sir,
didn't
we
hear
didn't hear.
you.
Okay, sorry. I just observed that it's like my microphone was muted briefly.
All
Okay.
right, sir.
Now,
All right.
I was apologizing for that disruption in the network. I think it was from my end because I observed that it's like a call was trying to come into my phone. Meanwhile, our internet is not working, so I'm using my phone internet as a modem for my laptop. So as call was trying to get onto the phone, it interrupted the internet service. So I'm sorry for that. Okay. Now, so that was the explanation I was trying to give. So let me share my screen again. Yes. Can you see my slide now?
Yes, sir.
On discharge summary. Okay, yes.
Yes,
Sorry
sir.
for that interruption again. Yes. So I was talking about this common challenge in physiotherapy where we don't get our patients to the point of discharge. And I was saying that it is often because we don't practice outcome-based practice. A good number of times, our record is not even detailed. And especially for some of us that practice in teaching hospitals, you will discover that when it is time for maybe some undergraduate physiotherapy students to carry out research and they want to review case notes or physiotherapy cards in the clinic, that's when they come up with a lot of headache because the record they see cannot be used for research because they are not detailed, they are not specific, they are not clear. And it is the lack of such clarity that makes it impossible for us a good number of times to get our patients to the point of discharge. Why? Because if we had been monitoring outcome, we will discover that it is possible for you, as you are managing a problem in a particular patient, to see through your outcome measurement that the problem was getting resolved much. And then the time comes, even though the problem has not completely disappeared, but your measure has become stagnant. Take, for example, if hypothetically, the patient is having chest pain. I want to try as much as possible to relate it to cardiorespiratory. The patient is having chest pain. Or let's even say dyspnea, and you are using your box scale of perceived exertion, and initially the patient, reported 8/10, and then you started to treat, and in a time frame of 1 week, it came down to 6. In another 1 week, it came down to 4. In another 1 week, it came down to 3. Then over the next 5-6 weeks, it remains at 3. You don't say because there is still 3, the patient should keep on coming. That tells you that that situation has plateaued. It's a good point of discharge. So a good number of times, because we are not able to monitor outcome and take decision to discharge patients, most of our patients, they discharge themselves. They get tired and they stop coming. Rather than we sitting down, analyzing their status and saying, you are good to stop coming to the clinic, or you are good to be discharged. You discover that patients that are on admission on the ward, a good number of times, it is not that the challenge has absolutely disappeared before they are discharged home, but their condition have become stable enough that they can leave the hospital bed. So likewise, the patients we treat, the situation can become stable enough that they can be discharged. So we must get our patients to the point of writing a discharge summary. And the summary should review all the problems that were initially identified. And depending on the status, we should still be able to encourage continuity of care if necessary. For example, you can discharge the patient and say, you don't need to come again, but if it appears as if the thing recurs or reappears, then come anytime you observe such. So you have left the door open for continuity of care. So the problem-oriented approach has become, a kind of standard across a number of disciplines in healthcare because it has a number of advantages. One of which is that it is able to map and monitor changes in the patient's condition. And in cardiorespiratory physiotherapy, we need that. And because it can monitor change, it can document the effectiveness of our treatment. It enables us to be able to communicate with third parties, whether insurance companies, attorneys, or other, physicians or other healthcare professionals that are also handling the patient that we see. So the justification for this approach that we advocate include: one, when patients come to the clinic, they come with problems, not with diagnosis. Some of the problems that they present with, they lack specific pathological basis. And when we treat, we don't address medical diagnosis in our treatment, but rather we address specific problems that patients have. And so it is advisable that we use the problem-oriented approach in our practice. Now, it also enhances teamwork because, we can all look at the data and get salient information, useful information that will advise our various multidisciplinary line of intervention. So we said the problem list can be used to coordinate care. It can be used to communicate effectively about the patient, either with the patient or among the healthcare team. Now, another advantage of this approach is the goal orientation. Because it is problem-oriented and goal has been set along the line of the problem, then our practice can be goal-centered or goal-oriented. Let me give us an example. A patient has a problem that he cannot independently expectorate, even though there is congestion in the chest. We now plan how we want to remove that congestion, how we want to improve the ability of the mucociliary clearance machinery. And then we now set a goal. Since the problem is inability to independently expectorate, in writing the goal, we say Mr. X will be capable of independent expectoration after 10 treatment sessions. You can see that in stating that goal, I've had to observe the acronym SMART. We are specific in the goal that we are setting, in that the goal is independent expectoration. And why did we fix that goal? Because that was the problem the patient had: inability to independently expectorate. So in setting our goal, we are hitting the nail on the head. We are addressing that very problem. The Mr. A shall be capable of independent expectoration. That's a specific goal. And it is measurable in the sense that when he is capable of doing it, we know he's capable of doing it. When he's not yet capable of doing it, we know that he's not yet capable. So it's measurable. It's something we can say, yes, it has happened or not. In stating it, we want to be sure that all things are such that that goal is achievable, in that we should not set unrealistic goals. And the goal is relevant to that patient because the chest congestion is disturbing him. He's bothered that he wants to cough and he cannot bring it out. So if he's now able to do it, then it becomes relevant to him. And then we have said that will happen after 10 treatment sessions. So the T, time bound. So we discover that this practice is goal-oriented. So we now work towards achieving the goal that we have set, which is meant to address the problem that was originally identified. And the practice puts the patient at the center because, we are addressing what gives concern to the patient. I'll skip this. Skip this. However, we must be balanced in the presentation of this advocacy. As good and as beneficial the approach is, it has a few drawbacks. The first one is the issue of the time that it consumes, and that often at times, the time allotted to provide care to each patient puts the therapist, under pressure to practice the problem-oriented approach. However, there are ways out. If we will try to engage in patient scheduling, this antidote here is that in a good number of our clinics, we simply give patients the day to come. We don't give the time to come. So eventually, you are booking 10 patients for a particular Tuesday, and all the 10 of them arrive before 8 a.m. And you cannot see all of them at the same time. You begin to see them one by one. Before you get to number 6 out of 10, everybody is becoming edgy because they've sat down in the clinic for so long. And so that puts the therapist under pressure to want to quickly attend to everybody so that they can go off his neck. But if you have actually scheduled, a patient is to come before 8, another patient is to come by 8:30, another patient at 9, another one at 9:30, another one at 10 a.m. You discover that as they keep to their time, each of the patients will not have to stay long in the clinic before he or she is attended to and she goes. And you will have had factored in the sufficient period you need for each case in the booking of the patient appointment. The second drawback is that a good number of times there is insufficient financial incentive, for such practice, because it's a comprehensive practice. And so a good number of times in this environment, you look at it that, oh, how much am I earning, for that matter, that I will now have to kill myself with work, that I will now have to go into all these details and go to this extent in managing patients. What do I get in return for all this effort? So these are some of the drawbacks for this approach. And a major disadvantage is that it takes time for people to learn to use it effectively. And during the day, to make the entries into the record, demands for some extra time from the practitioner. So that is the first topic for us. I wouldn't know if there is any question before we move on to the second topic. Questions, comments? Hello? Hello? Hello?
Hi.
Yes. Any question, comment before we move on to the next topic?
Hi, sir.
Yes. Please, you have the floor. Ask your question. I thought Mr. Muhyiddin wanted to say something. Mr.
No,
Muhyiddin,
sir.
okay,
No, I
okay,
don't.
okay. Okay, in the absence of any question, it's just a foundational thing. Can we just, in 2 or 3 minutes, stretch our legs and whatever? We are physiotherapists. We have sat down for about an hour. So let's stretch our legs. Are we all back?
Yes, sir. I'm
Okay.
back.
Yes, we're back.
Okay. Yes. So, once again, we are welcome. We are moving on to the second topic now: physical diagnosis in cardiorespiratory physiotherapy. Now, when we talk about diagnosis, a good number of times, depending on the environment where we practice, there tends to be some strange beliefs. In particular, in Nigeria, when you talk about diagnosis, there's a particular group that immediately feels so protective. This is our territory. Don't come there. And by the time we look at this subject matter, we discover that it is a product of misunderstanding of what that terminology is all about. And some of us also in the profession of physiotherapy, we think that this subject of diagnosis is restricted to some people, and it is outside of our scope of practice. But I want us to know that it is not, when we fully understand what it entails. Therefore, let's start from what does that word diagnosis imply? When you look at gnosis, it talks about knowledge. You talk about the Gnostics, the learned ones, those who are knowledgeable. Dia means true and true, just like you have dia in diathermy, because that's a thermal agent that can penetrate through and through, like you have the diameter of a circle that touches the two sides of the circle, that goes through the entire circle from one side to the other. So when we are talking about diagnosis, we are talking about thorough knowledge, thorough insight into what's going on. Therefore, any clinician that is going to be able to help a patient presenting with a problem requires to have that thorough knowledge, that thorough insight into what is wrong with the patient, if he's going to really be able to help the patient. So diagnosis is described as a concise, technical description of the cause, the nature, or manifestations of either a condition, a situation, or a problem. Therefore, if we have just spoken about problem-oriented approach to treatment, whereby you need to identify the problem, and then you have to tailor your plan to resolve that problem, you will only be able to solve that problem when you have a thorough understanding of its description, what it really is, what has caused it, its nature, its manifestation. Therefore, it is important for every clinician to have this skill. So, diagnosis is the art of applying scientific methods for the elucidation of problems that are presented by sick individuals that have come to seek their intervention. And to carry out diagnosis, it involves certain steps: collection and critical evaluation. You must collect evidence. You don't collect just a few, but all the evidence that are related to the problem that the patient is presenting with. You collect all the evidence without leaving any stone unturned. After collecting the evidence, which you actually seek for from every possible source. In other words, take for example, a patient comes and there is a carer that has come along with the patient. There are some information you will need to get that the patient himself or herself may not be able to furnish you, but that the carer can be armed with. So in your effort to collect evidence, you do not limit yourself to just the patient alone. You also ask questions. You request for information, even from the carer, that are relevant and that are useful, especially where such information is not available from the patient himself or herself. And in collecting evidence from every possible source, you use whatever method that is necessary to get it. And after collecting all the evidence from every possible source by any method necessary, you critically evaluate the evidence. These are the steps or procedures that are involved in diagnosis. Now, as physiotherapists, let's just ask ourselves, when you are clerking your patient, do you not carry all these things out? So if you are already carrying these things out to have insight into your patient's condition, who then told you that you are not carrying out diagnosis? And then, from all the facts that you have obtained, added to the knowledge of basic principles that we have already learned from the various courses, anatomy, physiology, kinesiology, pathology, every principle that we have learned, we form a concept about the situation. We form a concept about the etiology, what must have been responsible. We form a concept about the pathologic lesion. We form a concept about the function that have become deranged or disordered. The entire concept that constitutes the patient's disease. That concept is the diagnosis. And so, physiotherapists carry out diagnosis. Diagnosis enables, concerning each individual patient, the placement of the disease in a recognized category. You can then know whether it is an inflammatory disorder, whether it is a degenerative disorder, whether it is a progressive disorder or a non-progressive disorder. And by the time you have been able to place the condition in a recognized category, it gives you the basis for your line of treatment. Take, for example, if the patient now has pain, is complaining of pain, and by the time you have collected all the evidence from all possible sources by any necessary method and whatever, and you have related it to certain principles of neurophysiology, nervous pathway, pain conducting pathway in the cord and in the brain and everything. And you come to say, this is nociceptive pain, as different from neuropathic pain. Then, as a physiotherapist, that ability to categorize that pain and say this is nociceptive pain and not neuropathic pain provides you the basis for your treatment, because there are physiotherapeutic modalities that are suitable in managing nociceptive pain that will not address neuropathic pain. There are modalities that will address neuropathic pain and will not address nociceptive pain. So you can see how your ability to place the disease in a recognized category has formed the basis for your treatment. And then you can actually prognosticate to say, this is the likely outcome in this patient. So you can see how necessary this process of diagnosis is in our practice. But when we talk about diagnosis, we need to know that there are different types of diagnosis. And that's where the issue lies. You know, that's not the focus of our discourse today. When we talk about types of diagnosis, we have close to 20 types of diagnosis. But as physiotherapists, the kind or type of diagnosis that we engage in is physical diagnosis. While some engage in laboratory diagnosis, you know, histologic diagnosis and things like that, we do not go into those realms of diagnosis. Our scope is within physical diagnosis. Therefore, in patients with cardiorespiratory disorders, physical diagnosis simply means diagnosis that is made by means of physical means, not through chemicals that are, as you use chemical and reagents in the laboratory. So it is the determination of disease by 4 specific processes: inspection, palpation, percussion, and auscultation. So in other words, it could be said that we carry out our physical diagnosis through the process of physical examination. That's the method we use to arrive at our clinical decision that we use to identify and place certain diseases in various categories. And this we do under 2 aspects of our SOAP format: the subjective assessment and the objective assessment. For example, when we inspect, when we palpate, when we percuss and things like that, we arrive at subjective information. Then when we actually take certain measurements, physical measurements, we arrive at objective data. And so this constitutes the realm where we do our diagnosis. It is as we do that that we can now proceed to the analysis of findings. Now, in patients with cardiorespiratory disorders, what does our subjective assessment entail? We collect history of the client, you know, from family, you know, about the family, about the individual, history about, you know, habit of smoking, use of drugs, you know, the history of allergy, travel, place of residence, nutritional status or dietary history, occupational history, you know, as well as socioeconomic level. All these are subjective data that we collect from the patient. And let's mute that microphone at that end. Okay. Now, we also assess health problems that the patient is presenting with, like cough, the sputum production, the chest pain, the breathlessness, or dyspnea. You know, all these come under subjective assessment before we move on to our objective assessment, where we now carry out measurements. And in some instances, if it is going to support our information, we may lay hold on the results of some laboratory investigations. Take, for example, you have a patient that is complaining of back pain. Permit me to just deviate into that. It's just to illustrate what I'm trying to say here. And is complaining of back pain, and then X-ray is done, radiologic report is provided, and you suspect Pott's disease because there is a history of cough in that patient. A laboratory analysis to test for tuberculosis can be useful, can provide useful information to you as a physiotherapist to either confirm or to dispel any opinion you may have concerning what is happening in that back. So in cardiorespiratory condition also, there are some laboratory investigations that can shed some additional light on the situation of the patients that we are seeing. Imaging studies, X-ray, that's the physical. And then there are some tests that can be done. We have simple tests, we have some complicated tests, that we carry out in cardiopulmonary physiotherapy. One of the complex one is the cardiopulmonary exercise testing, CPET. Other simpler ones include the spirometry and things like that. So we have tests that we can also carry out to collect objective data that we can analyze to arrive at an accurate picture about the patient's problem. So how do we go about this? Our physical assessment. We look at everything that pertains to the respiratory system and the cardiovascular system. When we talk about the respiratory system, it starts from the nasal cavity through the airway, upper respiratory tract, lower respiratory tract, into the lungs. The thoracic cage that houses the lungs, because the movement of the thoracic cage is responsible even for the movement of air in and out of the lungs within the cavity. So all this, we assess the sinuses. We assess, the lungs, the thorax, through those 4 steps that we had mentioned under physical diagnosis: inspection, palpation, percussion, and auscultation. And of course, we are all professionals. We know of the use of these procedures. And as simple and basic as each of the 4 processes that are mentioned appear to be, they are very, very important Take, for example, inspection or observation. A great deal of information can be gathered simply by just watching the patient breathe. That if you do not take time to observe, you may miss the true picture of that patient's condition. And therefore, on this slide, we have things that you have to pay particular attention to when you are inspecting or observing. The general comfort of the patient, the breathing pattern, the color of the patient, the skin, especially the nail beds. It is usually said that blue is bad, and because it indicates cyanosis. The position of the patient. How's the patient sitting? A lot of patients, when they have respiratory distress, they assume what we refer to as the tripod position. And immediately you see your patient sit in that tripod position, that position alone is already speaking some volumes to you about the state of his health. Breathing through paused lips, ability to speak. As the breathlessness increases, ability to speak declines. You pay attention to any noise that is audible with breathing. You observe the abdominal wall movement. In inspiration, there should be an outward movement, thoracic expansion. For example, there are patients that can have paradoxical movement, where there is indrawing of the rib cage with inspiration. And that talks about a barrel chest deformity. That talks about flattened diaphragm. So immediately you see that, you are already drawing an inference. You pay attention to any deformity, either of the chest or of the spine. You look at the comfort of the patient and his breathing pattern. Do they appear distressed, and so on and so forth? Is he using accessory muscle? And that talks about increased work of breathing. The color of the patient. We said around the lips, the nail beds, the position of the patient. You can see that old man, the way he's sitting, the so-called tripod position. Breathing through the paused lips, inability to speak. How many words can he speak? Can he continue? Can he even sing? Can he make a statement? Or he speak one word at a time? That talks about the magnitude of the breathlessness. Audible noises. What's the nature of the noise? We have what we call the abnormal breath sounds. We've got to be familiar with sounds. What causes it? And therefore, what inference can we draw when we hear a particular type of breath sound? The direction of the abdominal wall movement during inspiration. I've already mentioned that in terms of paradoxical motion. The chest, as well as the spine, the symmetry, any deformity, bilateral comparison. We have some diagrams of some chest deformities, pes cavus, pes carinatum, humpback or gibbous. So we can see scoliosis, kyphosis, Then the lung anatomy in terms of the surface markings. And to be able to describe accurately, we have what we call reference points and reference lines, either anteriorly, posteriorly, or laterally. So we can see this image of the anterior thoracic landmarks. And we can see the tracing or the surface anatomy of the dome of the diaphragm in this illustration. And so when we want to describe the location of any tenderness or spot that we observe, we can describe them in relation to these landmarks. So we can talk about intercostal space, talking about the spaces between the ribs. We can talk about the position relative to the sternum. We can talk about the position relative to the clavicle, supraclavicular, infraclavicular, mid-sternal, And posteriorly, we have the ribs. We also have the vertebral bodies. And we can also still talk about the intercostal spaces, even posteriorly. And then we have the scapula, the spine of the scapula, the angle of the scapula, both superior and inferior. We have the spinous process. So we can describe lesions in relation to the nearest landmark, either bony or otherwise. Now, there is also the surface anatomy of the lungs in terms of the lobes that are affected, and we can relate to those diagrams. Laterally, then the reference lines. So that when we are making notes and we are describing reports of our assessment or examination, we must learn to use standardized terminologies. Standardized terminologies. It is when we use such that other professionals can easily understand our writing, understand the patient's situation, and can take over management from us in case of our absence. And that's when we can also communicate to other healthcare professionals about the patient that we are handling. These are the posterior reference lines, the lateral reference lines. Now, during the stage of inspection, we look at the chest, both from the back as well as from the front. And the rule is that the patient must be sufficiently undressed for us to be able to observe all we need to observe. So when we are examining or when we are inspecting the thoracic cage, the chest, we should be without the shirt. If it is the male, he can put it off. If it's a female, the bra can be on or with a singlet. We want to look at the shape and the configuration of the thoracic cage. Is this symmetrical or asymmetrical, especially bilaterally? Are the spinous processes in line, or is there any shift? The scapula on the two sides, are they symmetrically positioned? What's the anteroposterior diameter relationship. In other words, anteroposterior diameter in relation with the much larger than the anteroposterior diameter. Where the anteroposterior diameter begins to approach the size of the lateral diameter, then we talk about barrel chest deformity. So we watch the person breathe in and out to observe the respiratory movements. We look closely at what muscle is being used for breathing. Ideally, for inspiration, the diaphragm is the main muscle of inspiration. The participation of other muscles aside from the aside from the diaphragm, is indicative of respiratory distress or increased work of breathing. What position is the patient assuming? And so on and so forth. Then we observe the respiratory rate and the pattern, the sequence. We look to see if the breathing is deep or shallow. Is it regular? Is the patient breathing easily or is having difficulty breathing? And sometimes the difficulty can even be expressed from the facial expression. So we observe the face of the patient while seated at the examination table to see if the patient is in distress or not. Is the patient able to converse easily? Immediately there is respiratory distress, ability to converse will become compromised. Then we move on to the next step in physical diagnosis, which is palpation. And that's where you use your hand to feel, feeling with the hand. And the entire chest should be palpated, both anteriorly as well as posteriorly. You want to palpate to see whether the expansion is symmetric or not. You want to feel whether there is any transmitted sound to the surface of the thoracic cage that you can feel with your hand, the tactile fremitors. And when you want to carry out palpation, it is usually advisable that you start from the posterior chest and you allow the patient to get accustomed to your hand, because the anterior chest is a bit more personal. So when you are palpating, the things you look for, as stated here, symmetric expansion, you can see the position of the hand, the two thumbs, placed over the spine, such that when the patient breathes in and the thorax expands, the thumbs are separated from one another. You can then observe how much of distraction do you have on the left side and the right side. Is the distraction equal on both sides? Greater distraction on one side over the other might be indicative of diminished chest expansion on the side where you're having smaller amount of distraction, which sometimes may point towards atelectasis or other things like that. Palpating for the tactile fremitus. You can see the placement of the hand and the instruction you give the patient to make some sound and feel whether the sound is transmitted, to your hand. While you use the palm to palpate for symmetric expansion and others, when you are palpating, either for lumps or masses or tenderness, you use the fingertip and not the palm. After you finish with the posterior chest, you now come to the anterior chest and you repeat the procedures. The third method of physical diagnosis is percussion. And that's where you make some striking movement to produce sound that are characteristic based on whatever is the nature of the underlying tissue. There's the saying that empty barrels make the loudest of noise. So when you percuss over the lung field, because of the air filling the space there is a resonating sound. Whereas when you percuss over regions that are filled with either flesh or fluid, you produce a dull sound. And so sometimes you might, even with your percussion, be able to feel where the heart underlies the anterior chest wall. And you can map out a rough or an approximate size of the heart as you carve out what we call the area of cardiac dullness, because the heart contains fluid over that region in the thoracic cage, which will normally produce a resonating sound because of the lungs. Over the heart, the sound is dull because of the fluid inside the heart. And so sometimes, even roughly, one could arrive at hypertrophy, ventricular hypertrophy, in that issue, which you can then probe further with more sensitive tests to confirm your suspicion. This is showing us the area where you come across some dullness rather than resonance. You can see the area of cardiac dullness over the heart. Over the liver, you have the liver dullness. And for the stomach, you have the stomach tympani. Other areas where there is air beneath, you get a resonating sound. This is illustrating percussion. And then the fourth method of physical diagnosis, which is auscultation. Auscultation. Now, this is an area where a number of physiotherapists are not too conversant. But I want to advise that, especially those of us that are in the specialty of cardiorespiratory physiotherapy, to train ourselves up. Thank God for the age of technology. If you get online, you can download the different breath sounds. I have them on my system. downloaded already. And you listen to them over and over again to get accustomed to the nature of each type of sound. So that when you now pick the stethoscope and you auscultate on a patient, you can easily match the sound that you are hearing with the ones you are familiar with and say, this is the type of sound that I have had. A good number of times, when you see physiotherapists use the stethoscope in the ward or in the clinic, they end up drawing some inference that is not too accurate. Permit me to say that. Some people will use the stethoscope, and when they write, they say reduced air entry with auscultation. Now, we are all scientists, and let's analyze it. When we say reduced air entry, what measure are we trying to bring out there? Flow. Air entry is about flow. Is the stethoscope a device to assess flow? A stethoscope is a device to listen to sound. Even though the sound that you hear may now be suggestive of certain things, but the primary thing you hear when you listen is the characteristic sound underneath your stethoscope bell or stethoscope diaphragm. Therefore, in writing, when you auscultate, the first thing we want to see is what sound did you hear? By the time you now mention the sound you had in that location, we will then be able to say, at that location, is that the usual or typical sound that should be heard or not? We will then know whether there's an abnormality. We may then go ahead to other inferences based on the appearance of such a sound in such a location. But that's not the primary deduction from the auscultation. So for somebody to pick the stethoscope and auscultate, and the thing he wrote down is reduced airflow, places a query on the understanding of the purpose or the usage of the stethoscope. And we should correct that because it has been observed. So we said, you should use the flat diaphragm of the stethoscope and you should compare one side with the other. If you look at the patient over whom auscultation is being performed here, you see the numbers that are written. And you see that each number is replicated on the opposite side. So you have one on the right side, you have one on the left side. 2, 2, 3, 3, 4, 4, 5, 5, 6, 6, 7, 7, 8, 8. So you can see that, so that you can do a bilateral comparison. And as you do it posteriorly, you also do it anteriorly. Now, this brings us to the issue of the breath sounds. Now we talk about the normal, and then we talk about the adventitious. But there is something I want to bring out here. When you look at the normal breath sounds, we have bronchial, bronchovesicular, and vesicular. They are characteristic of what lies underneath. Bronchial sound is produced as air flows through a tube, a hollow tube. It is characteristic of air flowing through a hollow tube. For example, I think they still use it now. There's when this sewing thread that tailors use, there's a plastic tube around which the cotton thread is wound round, and it's a bit long with a hollow cavity inside. If you put that tube in your mouth and you try to blow air into it, as air flows through that tube, there's a kind of characteristic sound that it will produce because air is flowing through a hollow tube. That's what the bronchial sound sounds like, because that's what is producing the sound. But if that tube should be engorged with fluid, the presence of excessive amount of fluid inside that tube, it will affect the nature of that sound. And depending on to what extent the lumen of the tube has been, compromised, will then determine whether you are going to hear a wheeze or a stridor. Now, bronchovesicular, when we talk about the respiratory airway, from the trachea, the airway begins to bifurcate, break into two branches. The next one breaks into two, the next one breaks into two. And we have 23 generations of such branching in the airway. The first 16 of such generations do not have any associated alveoli. So they are referred to as the conductive airway. They simply conduct air from the atmosphere into the lungs. They are conductive airway. So along their length, you hear the bronchial sound. But a time comes, by the 17th generation, you begin to have some alveoli associated with the bronchus. And then by the time you now go down, you now have the respiratory airway because you have associated alveoli. So the 17th generation, because that's where some alveoli begin to appear, the 17th generation is referred to as the transitional airway. And then the last 6, respiratory airway. So we have conductive, transitional, respiratory in the 23 generations of bifurcations. Now, in the area where you now have some alveoli with some of the tube, the kind of sound you hear is a mixture of air flowing through a tube and filling a cavity, the alveolar sac. And that's the bronchovesicular. Whereas at the extremities, especially at the base of the lungs, where you have what we refer to as the acini, which is an accumulation of alveoli, alveolar sacs. The characteristic sound you hear there is sound filling air sac, and that's the vesicular sound. Where I am therefore going now here is this. In some parts of the lung, where you have some associated alveoli with the bronchi, if there is atelectasis, in other words, the alveoli to be collapsed, in the places where you should now have bronchovesicular sound, because the alveolar sacs are collapsed, only the tubes remain. You are going to hear bronchial sound in that place. Therefore, the fact that we have listed bronchial sound as normal sound here, it is possible for you to record bronchial sound somewhere and that bronchial sound is abnormal, because you are hearing a bronchial sound where you ought to hear bronchovesicular sound. So that bronchial sound is abnormal there. So it's not in every place where you see recorded bronchial sound that the bronchial sound is normal. And that is why in recording things as a cardiopulmonary physiotherapist, you must be detailed and thorough in your recording. The bronchial sound you are reporting to us, where did you hear it? Because that will guide our interpretation to know whether it is normal or not. The fact that it's bronchial is not automatically normal. Now, we come to the adventitious breath sounds. Again, each of these sounds that are listed here, the crackle, the wheeze, the roncus, the pleural friction rub, and whatever, there are characteristic features that produce them. So that when you hear, when you record, or when you see that sound recorded or listed, it immediately gives you an information, because you know what should produce that type of sound. Now, other assessments that we do, the voice sounds, as you ask the patient to phonate or to speak, bronchophony, whispered petriloquy, egophony, and things like that. You observe the skin and the mucous membrane, to assess any presence of cyanosis, which is an indication of oxygen saturation in blood and things like that. That has to do, that will give us a lot of information about the gaseous exchange at the, in the lungs, or even transportation in blood, the availability of hemoglobin or otherwise. And we know that when we talk about hypoxia, we have different types of hypoxia. Therefore, when we are recording all these things, our recordings should be comprehensive, such that it will point to what we want. And then we also spoke about the fact that there are some other tests or assessments that you can actually carry out that will corroborate or confirm your suspicion and things like that. In a case like this, you may then want to do pulse oximetric measurement where you use the pulse oximeter, which will actually measure the SpO2, which is the arterial oxygen saturation. Talking about the voice sounds, what you ask the person to say and do, and then what you hear, what could be wrong, and things like that. So, like I was saying, that each of these sounds, they are characteristic of certain things. So we can see them listed. Why bronchophony? Why egophony? And why whispered petriloquy? Then we move on to psychosocial assessment. Remember that when I was talking about the problem-oriented approach to treatment, I spoke about active problem and inactive problem. And so it's possible for psychosocial issues to be inactive problems in some of the patients that have cardiorespiratory challenges. So we said some respiratory problems may be worsened by stress. So if, permit me to be a bit mathematical, and the mathematical figures I want to ascribe are not absolute, they are just illustrative. Let's look at a patient having a symptom. I don't want to name any particular symptom. Let us call that symptom symptom A. And that symptom A is sensitive to the amount of stress being experienced by the patient. Now, you now have two patients, both of them having this symptom A. In patient number one, let's say the magnitude of A that you assess, let's give it a mathematical figure, is 8. In patient B, the magnitude of symptom A is also 8. But in patient 1, there's a lot of stress that your assessment, your history taking and whatever, revealed. You will then discover that patient A and patient number 1 and patient number 2, they are not having the same severity of that symptom A. Because in patient number 1, the magnitude of A is 8 because of the impact of the stress. If the stress were not to be there, magnitude of A could probably have been 5. Which means that patient number 2, who had no stress and is having a magnitude of A of 8, is actually having a more severe symptom A than patient number 1. So you can see where certain comorbidities and these inactive problems can paint the picture of your patient, and therefore why they must not be neglected or overlooked. Thank God, most of us, even before we began to maybe narrow down to cardiorespiratory physiotherapy, we've had to rotate around various specialties and whatever. And we had a time when we rotated around orthopedics. In orthopedics, they also have some tests. And you are familiar with that. They will say that some tests can produce false positive. You know, when you have tests and you say, if it is positive, it means so thing is present. Then you now have somebody, that thing is not present, yet the test is showing positive. And they say, oh, it is a false positive. Why is it showing positive, which is false? That means there is something else underneath, different from what should have made or produced positive, that is causing the positivity. There's an underlying thing. So here, you see distress as an underlying factor, giving a reflection of magnitude 8 for symptom A, whereas that symptom is not as severe in that patient as it is in the other one. So to neglect that hidden factor, to overlook that underlying thing, can make you to draw an inference that is not accurate. And that's why we cannot leave any stone unturned. You don't ignore any problem, whether active or inactive. So we said chronic respiratory disease may cause changes in family roles, social isolation, financial problems, either due to unemployment or due to disability. And, you know, in some climes, there are some support systems that are available to people. In Nigeria, you hardly come across support systems beyond immediate family. And a good number of times, even the immediate family may soon get tired of the burden of supporting a particular patient. And then things begin to deteriorate. Now, even though I said that as physiotherapists, the type of diagnosis we do is physical diagnosis based on those 4 steps, that does not absolutely preclude some laboratory information. For example, even the so-called pulse oximeter that we can measure can be classified as a form of laboratory test, because it is looking at the flow of blood and talking about the presence of certain agent, which can be referred to as a chemical. Carbon dioxide is a chemical. Oxygen can be seen as a chemical, because it is even a drug, because there are people that are given oxygen, as administration. So we have some of such, some blood tests in terms of the PCV, where you have a patient that is anemic. The report of the blood test, like the PCV, can give us some information. And a good number of times, even when we have the PCV, it may not provide sufficient information in cardiorespiratory physiotherapy, because we know that apart from the fact that there is a packed cell volume, there is also the issue of the actual size of each erythrocyte. And that's why we have variables like MCH and MCHC. That's what, mean corpuscular hemoglobin and mean corpuscular hemoglobin concentration. So that when we are talking about anemia, anemia can be classified. We can talk about hypochromic anemia. So, such things, it is as we lay hold on some of this other information that we can now go to that extent of inference. And that extent of inference can influence our line of intervention. Because when we have that added information, it may tell us whether the line of intervention we intend to use can be sufficiently effective or not, or we need to add something extra to what we are planning to do. Sputum tests, which may be suggestive of infection. Because if the patient, with chronic bronchitis, it is possible for somebody to have chronic bronchitis and the sputum is not infected. The productive cough is simply as a result of inflammatory process in the mucous lining of the airway. But with the chronic cough and whatever, if hygiene is poor and socioeconomic status is low, the patient is at a higher risk of infection. So if infection now sets in, it can delay the resolution of the inflammation. So the sputum test, as a physiotherapist, without information about the sputum test, and you are handling a patient with chronic bronchitis, and the problem is chronic productive cough, you can begin to set a goal that the excessive secretion due to your airway clearance technique should clear over so period of treatment or over so number of treatment sessions. If you are ignorant or unaware that there is underlying infection and you set that goal, whereas there is infection, the presence of infection will slow down the success that you can attain with your intervention. Whereas if you have the result of the sputum test, there's a way it guides you in setting your goal in terms of your teeth, time-bound. Maybe if you are going to suggest that the problem will have resolved after 2 weeks, realizing that there is infection, and then possibly having information about what effort is being made to resolve the infection or not, you would need to add a little period to the 2 weeks as the time you are envisaging the resolution of that problem. So all these are things that guide our practice. Then the radiographic examination, of course, we need that information to guide what we do. And beyond X-rays, there are other imaging studies that can prove useful to us. CT scan, MRI, and things like that. And then, of course, ventilation perfusion scanning. It gives us, information about the gaseous exchange in the lungs. And then there is another test, which is even more sensitive than the pulse oximetry, because it has been reported that the values that you obtain using the pulse oximeter can be affected by certain factors. So that the fact that pulse oximeter says 95% saturation may not necessarily show that there is a balance in gaseous exchange. So there is another test that is referred to as capnography. Capnography. While pulse oximeter measures oxygen, capnography measures carbon dioxide. And so it is a more sensitive test than pulse oximeter, because it can actually tell you the level of metabolic activity that is going on, how much of the oxygen is being converted to carbon dioxide, the level of carbon dioxide production and everything, and show whether there is deficit that pulse oximeter will not show you. In essence, what I'm trying to say in that place is that where we have access to the capnograph, we should not be too satisfied with pulse oximeter reading. It would be nice for us to have the capnograph reading also and look at the two together to draw a more balanced inference. Now, of course, there is also the pulmonary function testing, or spirometry. The spirometry is the basic component of the pulmonary function testing. When we talk about pulmonary function testing, there are other more sophisticated tests than the spirometry. So this test, evaluate the lung volumes and capacities, the flow rate. So when we talk about the lung volumes and capacity, we talk about the tidal volume, we talk about the vital capacity, but in terms of the description of the procedure, it is not really the vital capacity that we measure, but the forced vital capacity. So it's the FVC that we often measure rather than just the ordinary VC. And then the flow rates, we talk about FEV1, and then we talk about the PEFR, peak expiratory flow rate, and the forced expiratory volume in the first 1 second and things like that. And such readings can differentiate our respiratory patients from those who are having restrictive disorders, from those who are having obstructive disorders. And sometimes also, the FEV1 in isolation may not give us a totally accurate picture, but rather we look at the ratio, FEV1 FVC ratio. It gives us a better clinical picture than either of the two in isolation. Then we also have the diffusion capacity. That's beyond spirometry. We have the gas exchange, we have the airway resistance, we have the distribution of ventilation. Well, the procedure and whatever, we can always get from various textbooks and guidelines and so on and so forth. Like I said, we are dealing more with principles in this seminar of today rather than the procedure. We are focusing on the principles that guide what we do. If we are to talk about what we do, that's better handled with practical workshop and things like that, hands-on practice. I believe that one of these days, we might be able to actually put up, a practical workshop. I wouldn't know whether we have some of our colleagues in Ogun State participating in this seminar, because about 2 years ago, we were supposed to have actual workshop with the physiotherapists in Ogun State, but somehow it didn't work out. We shouldn't rest on our oars. I think it is worth, going back to, whereby we can organize such a workshop in collaboration with some anesthetists and whatever, and then we can actually have even the mechanical ventilators, and then we do an actual hands-on workshop on the mechanical ventilator, looking at the various adjustments of the ventilator, the different ventilator modes and procedures and so on and so forth, even the suction machine and everything. Suction is still part of the scope of practice of physiotherapists in a good number of climes. Okay, now, so we have some other testing and follow-up care, exercise assessment, and skin testing, like in the case of tuberculosis, the Mantoux test, And when we talk about the exercise assessment, you know, we have the exercise stress testing. We can use the maximal protocol. We can use the submaximal protocol. And I'm sure we still remember that is that the Cavonian formula, where we talk about 220 minus age to give us an approximate value of the maximal heart rate. And then when we subject patients through exercise assessment or stress testing or training protocols, then we can either work based on certain percentage of maximal heart rate, or we can work a certain proportion of what we call the heart rate reserve, you know, either a proportion of the maximal heart rate or a proportion of the heart rate reserve. So these are principles that guide our exercise stress testing and exercise training and prescription. Activity and endurance evaluation, functional status, you know, and some of the tests that we can use for that, the 6-minute walk test, the 12-minute walk test. So that's the second topic. Again, any question? Okay. In the absence of any question, let me see. The coordinator, sir. Dr. Jibrin. Oh, there's a message. There's a chat. Let's read the chat. Okay. Dr. Jibrin.
Hello, sir. So,
I was saying that, do we have 5 minutes for people to stretch their legs and whatever, and for me to also drink water?
okay. Oh, can we have the break?
Now, it will be too early for us to have a long break now. I was thinking that if we let me see the topics and see what is next. The next topic is identification of problems and goal setting. Identification of problems and goal setting. Let me see. Okay, so how long is the break supposed to be?
Like 45 minutes to 1 hour.
That would take us too far. Is it possible to reduce it to 30 minutes?
Okay, let the participants
so that
decide.
we'll be able to cover much even when we come back, because we still have so much to cover.
Yes.
So is it possible for us to make it only 30 minutes?
Okay. Let's do it for 30 minutes. So that we resume by
1:45.
1:45.
Yes, sir.
So let's resume by 1:45. Thank you all.
Then we have the issue of the observations, the assessment, and the healthcare plans. Based on the patient's problem. Sure. And in terms of the capable. So it's measurable when we fully understand what it entails. Therefore, let's start from what does that word diagnosis imply? When you look at gnosis, it talk about knowledge. Talk about the gnostics, the learned ones, those who are knowledge, houses the lungs, because the movement of the thoracic cage is responsible even for the movement of air in and out of the lungs within the cavity. Active assessment, that description of the cause, the nature, or manifestations of either a condition, a situation, or a problem. Therefore, if we have just spoken about problem-oriented approach to treatment, whereby you need
Good afternoon, everyone. Welcome back. Can we continue with the presentation? It's 1:48 now. Come back at 1:45. Welcome back, everyone. So you can continue with the presentation.
Okay. Thank you very much. So let me share the screen. Welcome back, everybody. We are moving on to the next presentation now, which is identification of problems and goal setting. Now, like we said, the beginning of successful intervention in our patient's situation is the accurate identification of the problem, because it is immediately we identify the problem that we are able to map out appropriate strategy to address that problem and resolve it. So this particular topic is very, very important. However, when we look at cardiopulmonary disorders, there are so many, they are so variable that there is no way one within like half an hour to 1 hour want to deal with everything. Therefore, it's like we will pick some cases to illustrate the principle. Like I said at the beginning, the focus is the principle that guides our assessment, the principles that guide our intervention, the principles that guide our rehabilitation. So we are going to look at a number of cases as example to illustrate how we apply these principles. This issue of identifying the problems is a product of clinical reasoning. Remember, we said we start from the database. We collect data, both subjective and then objective. We lay hold on information from every possible source by any necessary means. We might even lay hold on some other information from certain other tests, either that have been carried out before or that are just being carried out as we are also engaged in seeing those patients. And now there is the process of analyzing the A aspect of the SOAP, subjective, objective data, and their analysis. So it is through our analysis that we highlight, that we identify the problem. And when we, carry out this analysis, we engage in a process of reasoning. What we can liken it to, especially, I'm sure that we all learned about clinical reasoning and whatever in school and whatever, and we learned about the different models. And we learned of the fact that professionals, especially at the early part of their career, they normally use what we refer to as the hypothetical deductive model of clinical reasoning. Whereas experienced people, by virtue of the number of cases they have seen and their track record and whatever, tend to use more of what we refer to as pattern recognition. Now, when we talk about the hypothetical deductive model that beginners and early career professionals use, it is similar to what we used to do in chemistry in the secondary school in those days, when we do what we refer to as qualitative analysis. I'm sure most of us will remember those practicals in the chemistry lab, when we do volumetric analysis, where we titrate acid against base to get the molarity and things like that. That's volumetric analysis. There is the other side of analysis that is referred to as qualitative analysis, where you are given a certain salt or crystal, and they ask you to identify it. I'm sure some of us will begin to relate with that aspect of chemistry. And then we will now begin to draw some hypotheses. First of all, you observe the nature of that crystal or salt. You either say that it is a salt, or it is a crystal, or it is a solid. Then you can take a little bit of it and you add water to it and you try to dissolve it in water. After you have noted that it is a salt, so is the color. When you try to dissolve it in water, you say it is either water soluble or not water soluble. For example, if it is water soluble, immediately all the other salts that are not water soluble, you knock them out. That salt cannot be one of those, because this one is water soluble. If it were to be one of those, it wouldn't have been water soluble. So supposing at the beginning, looking at it based on appearance, you have said it could be any of 8 possible salts. But by virtue of the fact that it is soluble in water. You knock out 3. You are left with 5. You now say, okay, let us see if it is acidic or alkaline. The little solution, you bring your litmus paper. You bring the blue litmus paper and it turns it red. You say this solution is acidic. So you look at the remaining 5 salts. How many of them are acidic? Maybe 3 of them are acidic, 2 are not acidic. You knock out the 2 that are not acidic. You say, since this one turned the blue litmus red, it must be acidic. Therefore, it cannot be any of these 2 that are not acidic. As you do that, you have narrowed down from 8 to 3. And you go on, you go on, you go on, until you do another test. You knock out 1 of the 3. You are now left with 2. Meanwhile, out of the 2, there is a particular one, you know the next property that, maybe it crystallizes after a certain time. And you left the solution for that period of time. It does not crystallize. And then you say, well, if it were to be this one, it should have crystallized. Since it didn't crystallize, it is not this one. Therefore, this salt is this. You can see the procedure by which you have arrived at the identity of that salt. It has involved a process of reasoning, analysis, reasoning, judging, eliminating some options, holding on to some possibility until you end up pinpointing which salt exactly it is. This is exactly the same process that is involved in clinical reasoning, especially when we talk about the hypothetical deductive model. That's why a good number of times, if you go to the medical clinic and you meet a young doctor, a lot of people complain about that when they come to government establishments like this. The young doctor will immediately carry several forms and call for so many tests. He can call for 6 tests, 7 tests. And they go to collect blood, collect urine, collect this for that and that and that and that. And then from the various laboratories, they bring the results. He will now sit down and begin to look at the result of the various tests. And then he will undertake this process of clinical reasoning by knocking off some possibilities based on the outcome of some of the tests. Now, in physiotherapy, we also engage in this process of clinical reasoning. Once we have collected the data and it is before us, we analyze to arrive at this is the problem that this patient is having. So, clinical reasoning is vital for the efficient management of patients with respiratory disorders. So when we talk about clinical reasoning, it aims at pulling all results of assessment together, analyzing them, and then making inferences and then plans to address individual problems. So when we are talking about patient management, it is clinical reasoning that justifies patient management, because that is what leads to the plan that is implemented. And for clinical reasoning to be able to take place, certain things must be observed. Number one, the documentation. Then, the consciousness of professional liability. Realizing that as a professional, you are liable. And therefore, you must do all due diligence to make sure that you are not careless, you are not negligent in what you are doing. Knowing that you have the responsibility to practice as to avoid litigation. And thirdly, commitment to practicing according to physiotherapy standards. The profession has standards that it expects every professional to be committed to, below which no professional should operate. And based on that, you have, a number of documents that state standards and guidelines. For example, while I was preparing for this seminar, I came across one article, and I went through. I even printed a copy because it is relevant. It's published by Vadicchio et al. 2023. It is published in Heart, Lung, and Circulation Journal. And the title of the publication is A Clinical Guide for Assessment and Prescription of Exercise and Physical Activity in Cardiac Rehabilitation. And it is a position statement by the association in New Zealand. So now, it is a clinical guide, meaning that clinicians practicing in that land, they are expected to practice based on this guideline that has been provided. So likewise, physiotherapy has standards and guidelines that are published. And that's the essence of evidence-based practice. So it is as the professional operates with all these things I've made mention of in view, that he will practice at a cutting edge and he will be effective and efficient in addressing the problems of patients. Now, let's look at the process that is involved in this process. Identify patients' physiotherapy issues. That leads to the formulation of the problem list. Then, as you identify the problem, you set realistic targets for improvement. And that's the treatment goals that you come up with. As you set your goals, you now devise management plan in order to achieve that goal. And that's your treatment plan. Then, as you manage and you measure you evaluate the impact of your intervention. Along the line, you modify your plan in order to get the best out of the patient. And those are the, middle soap notes as we go along the line. Now, what guides our clinical reasoning and that shapes the identification of the problem is that it is possible for 2 or 3 patients to have the same diagnosis, but have different problems and therefore treatment plans. And we are going to see that in some of the examples that we are going to treat. Now, on this slide, we have a list of some common complaints that patients with cardiorespiratory conditions will complain of: chest pain or discomfort, cough, dyspnea or shortness of breath, edema, swelling, fatigue or weakness, hemoptysis, leg pain on exertion, lightheadedness or dizziness, autopnea, or paroxysmal nocturnal dyspnea, pallor, cyanosis, palpitations, syncope or near syncope. These are common symptoms or complaints. Now, when we talk about problems, these are common problems that, are listed against patients: elevated cardiovascular risk, impaired ability, to protect the airway, retention of secretions, volume loss in terms of spirometry, increased work of breathing, reduced exercise tolerance. We are going to pick a few of these, and we are going to illustrate how you identify the problem and how you set your goal. Now, apart from those common problems that we have seen in the previous slide, we also have some associated problems like poor pain control, acute confusion, musculoskeletal disorders, unstable cardiovascular system, and so on and so forth. Now, let us now, first of all, pick one problem. You have flagged the patient, you have taken the history, you have done subjective assessment, you have done your objective assessment, and you have analyzed. And you say, oh, the problem with this patient is that the secretion in the airway is retained. In other words, there's accumulation of the mucus in the airway. Now, you discover that somebody who has this problem, it could have arisen from various causes. And in the boxes below, we showed possible causes. The first one is secretion retention itself. It's retained there. It's not moving. And why is it not moving? Because the mucociliary escalator, you remember the cilia that move in a flagella-like motion in the airway to move the mucus towards the trachea so that it can initiate the cough reflex, and then the patient can cough and expectorate the secretion. But now, it is possible. Take, for example, a patient that has just undergone surgery under general anesthesia, and therefore the mucociliary escalator is depressed by the effect of the anesthetic agent. So the mucociliary escalator is weak. So that person has a problem that the secretion is retained there and cannot come out. But another person has the same problem, retention of secretion. But in that person, it is not because the mucociliary escalator is weak in his own case. The mucociliary escalators are working. They move the mucus upward, but the patient is not able to expectorate it. Another person is also said to have problem of retention of secretion. In his own case, the mucociliary escalators, they are working. He is actually able to expectorate, but his cough is not effective. In other words, if you ask him to cough, say, and so the force that is generated by his effort is not sufficient to push out the phlegm. Now, there is the other person is also having retention of secretion, and the cough, the cough is depressed or absent. Now, look at 4 patients before you. On their problem list, all the 4 of them have retention of secretion. But from what is causing that retention, there is no common method to address this problem in all the 4 of them. The approach is different for each of them. Therefore, as a matter of principle, you cannot just say, oh, problem, retention of secretion, and then you want to begin to treat. You will miss it. You may not succeed in managing that patient. Let's now analyze what you may have to do in addressing this problem. Now, for the person, the first patient, where the mucociliary escalator are depressed, possibly by the effect of anesthetic agent. In that patient, the only way you can clear the airway of that secretion is artificially. That person is going to need the suction machine. You are going to have to suck the secretion out of the airway. In the other person, the mucociliary escalators are functional, but is unable to expectorate. Now, I'm sure that the older ones that are online, during your student days, you might not have taken courses in pharmacology, but the younger colleagues, they took some pharmacology. Although in some of the institutions, many of them didn't take systemic pharmacology. They only took general pharmacology. But if you are taking systemic pharmacology and you have dealt with pharmacological agents that are used for respiratory patients and things like that, let's look at cough syrups, the various cough syrups or various medications for cough to treat cough. There are at least 2 major classes of cough medications. You have expectorants, you have antitussives. Expectorants and antitussives. And they work with different mechanisms. The expectorants, they trigger you to cough so that you can expectorate the phlegm. Many of us are familiar with benylin expectorant. Am I talking?
Yes,
Hello?
sir.
You are familiar with benylin expectorant. So benylin is an expectorant. But you have some other cough syrups that are not expectorants, but rather they are antitussives. What do we mean? The cough is referred to as tussive, you know. And so a good number of times, people who have cough during the day like this, when they are moving around and they are active, they may not even experience the cough. It is late in the evening or in the night when they are now relaxed and they want to sleep. That's when the bout of coughing will come and the cough will disturb their sleep or will not even allow them to sleep on time. Amongst those ones, what will be prescribed for them is antitussive, something to suppress that cough so that it doesn't disturb. So that tells us that we have different types. So for somebody, therefore, who is unable to expectorate, in other words, that reflex is not initiated, what you need to do is to aid the initiation of the reflex. So the administration of an expectorant will assist that person to expectorate the mucus. But that won't be useful for the first patient, whereby the mucociliary escalator had not even brought the mucus near the throat. Let us now look at the third person, the third patient. In that patient, he is able to initiate the reflex, but the cough is weak. What you need to do there is to assist the cough. And there are procedures that are referred to as cough assist. That's going to be the line of intervention for that third patient, not an expectorant. Because even if you give an expectorant, it will only trigger him to want to cough. The cough will still be weak and not move out the sputum. Now, from this scenario that I have painted, I'm sure we can now see that these three patients I've even described, they have a common problem, retention of secretion. But the approach to solving their problem is different because of the root cause of that problem. Telling us, in terms of the principle of our approach, the principle is that you don't undo these things in the surface. You get down to the root cause, because it is only when you deal with it from the root that you can effectively and successfully deal with it. Now, how do we identify this problem? How do we arrive at the conclusion that the problem of this patient is retention of secretion? We can see a number of bases that would justify that inference. From the disease profile and the history, take for example, I gave an example of a patient that has gone through a procedure under anesthetic agent, and it is the anesthetic agent that had suppressed the mucociliary system. Now, maybe that person only went through an exploratory procedure, not really any incision or, there wasn't any cutting. They only had to do a kind of laryngoscopy, whereby they wanted to inspect the larynx and the airway. And they had to insert a scope with which to view the inside. And in order to avoid pain and everything, they had to sedate. And that was why they used the anesthetic agent. And the anesthetic agent had now suppressed the mucociliary escalator. So now, in the course of you taking the history of the patient mentioned and said, well, I was actually okay until about 2 weeks ago. And what happened was that the previous week, I had this complaint that I observed in my throat. And when I went to the hospital, they said they were going to look at it. So they had to look at it under anesthesia and whatever. And what I observed is that about 2 or 3 days after that procedure of looking into my throat, that's when I discovered that my throat, my chest is heavy, but I'm not able to really cough out what I feel that is blocking my airway. That's the narrative from the patient. Now, from that profile, from the history that the patient had given, alluding to the use of anesthetic agent, and you knowing the effect of anesthetic agent on the cilia, there's a way your mind already goes to why there is retention, and that it is fluid or secretion in the airway, and it is accumulating because the escalators are weak and not pushing it up. Now, another thing is to assess the amount of secretion that is expectorated over a period of time. This patient complains that he is feeling chesty, that there is, fluid in my airway and whatever. Maybe you now give him a sputum mug and you say, when you want to cough, anything you cough out, put it into this jar. And then the patient comes back the following day. And you try to assess the amount of secretion inside that jar. And you discover that it's as if somebody just spat into the place without any appreciable quantity of mucus inside that place. It's telling you that that liquid or that fluid is not coming out. That means it is being retained. Okay, an X-ray was taken. And the chest X-ray shows that there is consolidation in the lung field and there is presence of infiltrates. Fluid. When you ask the patient to cough, the cough is not dry. It is a moist cough, but nothing is actually coming out. That is telling you that the secretion is being retained. In breathing, you hear quas crackles. On auscultation, fine crackles in breathing. All this. You check the, gas exchange and, it is neither here nor there. You check the temperature. It could also be on either side, in that if there is infection of the secretion that is retained, the temperature will rise, indicative of infection. But if there is no infection, the fluid is just retained without being infected, temperature may not be elevated. The little sputum that the patient is able to bring out, you want to be sure that there is no infection. You sent it for sputum culture, and the result came out to say no infection. It tells you that he's not having an infectious respiratory disorder. So what is happening is plain inflammatory response to the insult of the procedure that was carried out on that patient. So going through all this, that's how you think and you analyze all these findings and you say, oh, the problem here is retention of secretion. Now, having identified that the problem is retention of secretion, and this patient is not able to expectorate unless you suction the thing. As you treat, you don't want the patient to perpetually be on a suction machine. So the goal will be that the patient should be able to expectorate independently. So you want to write down your goal. And the goal must be SMART. So S, specific. So what's the specific thing we want to achieve in that patient? The specific thing is independent expectoration. Okay. Because our goal must be SMART, how are we going to measure and ascertain that this goal is achieved? Oh, of course. Mere observation and patient report can assess that, in that presently he is not able to do it. When he is able to do it, he will be able to tell us that he is now able to do what he could not do before. We will ask him to do it in our presence, and then we can confirm whether he is now actually able to do it or not. So, that he is able to expectorate independently is measurable. Oh, it must be achievable. Now, we discover that it is the irritation and the suppression by the anesthetic agent that cause the retention. Literature has told us that if such effect of anesthesia will wear off in about 7 to 8 days. So, when we are going to set our timeline, we are going to make sure that we set a timeline that will be after the so-called effect of the anesthetic agent must have been washed off. If we now set the goal and say it should happen in the next 3 or 4 days, then the likelihood that that goal will be achieved is almost zero, because evidence has shown us that the mucociliary escalators will still be under depression in 7 days. So how do you now want him to expectorate independently within any number of days shorter than that? Okay, the R, relevant. It was this inability to independently expectorate and the feeling of heaviness in his chest that made him to leave his house, and he came to the clinic to complain, seeking for professional intervention. Therefore, if the problem is solved and is now able to do it, the goal of independently being able to expectorate will be relevant to him. So R is fulfilled. Then we come to T. Yes, we know that it takes 7 to 8 days. So we say the timeline that we are expecting for this goal to be accomplished is 12 days. So when we now want to write our goal statement, remember that there's a difference between the goal and the statement of the goal. It is the statement of the goal that must be smart. You must state it in a smart way. The goal ordinarily is independent expectoration. But how do we state it? We must state it in a smart way. Therefore, in stating this goal, we will say, if the patient's name is Mr. Hector, we will say that Mr. Hector shall be able to independently expectorate as a result of the intervention in the next 12 days. That's how we will state the goal on paper. If we write anything as our goal statement, and it does not fulfill this SMART criterion, we have not properly stated our goal. No. Another way we can set a goal for this patient, when he begins to independently expectorate, we are also interested in the volume of sputum that he will expectorate. So we can write the goal also in terms of the sputum expectorated. We can say that Mr. Hector will be able to independently expectorate up to so mils of sputum or mucus per hour in the next 10 days. Again, the goal is specific. Independent expectoration. Assessed through the volume of fluid expectorated. It is measurable in that we have measuring cylinder with which we can collect the sputum and measure the volume. It is achievable because we are already setting the goal to take place after the effect of anesthesia must have worn out, which is 12 days. And we are saying it is in this number of days, time bound. Another way we can state the goal. Remember that because of the retention, since the mucociliary escalators are weak, there was consolidation and infiltration, which is reflected in the chest X-ray. We can set the goal in terms of the resolution of the X-ray findings. We can say that the consolidation and infiltration in Mr. Hector's chest X-ray will have fully resolved in the next 15 days. Again, specific, we are talking about resolution of the consolidation and infiltration. So that's what we are looking out for. The method we are going to use is the radiograph. It is measurable in that we can look at the X-ray, and looking at the X-ray, we can tell whether the thing had disappeared or not disappeared. So it's measurable. In terms of being achievable, we have created sufficient space for it to happen. In terms of time bound, we have specified the time that we are going to check whether the goal is accomplished or not, 15 days. In terms of being relevant, that is the report he was given. And that's what he saw to be responsible for his problem. So if that is now clear and they give him report that, oh, that thing has cleared off, he will definitely be happy. That means it is relevant to him. Now, another way of writing the goal is in terms of auscultatory finding. Remember that because of the fluid, the sound produced by the air moving in that lung will be different because it is air that is supposed to fill all that area. And so we can say that the auscultatory findings will have disappeared or will have been totally resolved by so time. Now, I have used this example to show us that we can have multiple number of patients with the same umbrella problem, but the root cause is different. And therefore, approach to their management cannot be the same. We have also used this example to illustrate how you arrive logically by analyzing various data available, both subjective and objective, to identify what has gone wrong. We have also used this example to illustrate how we state the goal in a smart way and how we can use different outcome measures to confirm the achievement of the goal. That reminds me, during the last session, one of the questions that was submitted, the person said, how can we apply T to ward patients? In other words, when we are stating the SMART goal, the criterion of timing being time-bound, T of SMART, looking at patients that are on the ward that will not necessarily be there for 2 weeks, 3 weeks, or whatever. How are we going to state their own goal and make it to still be time-bound? Yes. Let me address that. Now, you can see from this example that we have shown to say that we have various options of outcome measure. So in such a patient, you look for what outcome can easily happen or take place or be assessed within the likely period that the patient will be on the bed. Take, for example, I just used, for the anesthetic agent, I just used hypothetically to say, evidence says that the effect of the anesthetic agent will wear off in 7 to 8 days. Realistically, it doesn't take such a length of time. So even if the patient is on the ward, after maybe within 48 hours or whatever, the effect will have gone. So you can look for what can be measurable within the time frame that the patient will be on the ward. There is no law that says it is a particular outcome that you must look for. No. We are free to be innovative. We are free to come up with measures that can indicate the success of our intervention. That's for that question. We have some other questions. What I will do is that I'll be answering them as we get to appropriate and relevant points in our presentations. Now, let's look at treatment plans for these patients. Look at the patient that is not able to expectorate. Starting from the simplest, positioning inside line. Because the mucociliary escalator are not functional, you will not encourage the upright position. Because in the upright position, it means that the secretion will have to move against gravity. And there is no natural means to move the secretion against that force. Secondly, you can remove the secretion artificially using the nasopharyngeal suction equipment. And of course, for the patient that has weak cough, you can use manual techniques, postural drainage position, clapping, shaking, and vibration. And in some instances, even to stimulate and to trigger effective cough, the individual can put a finger or the hand into the throat, and that will stimulate the cough. Another method by which the goal can be achieved is by using the airway clearing techniques, of which we have quite a number. We have the forced expiratory technique. We have the active cycle of breathing technique. We have the autogenic drainage, and so on and so forth. Can use any of such. So you can see how we have handled this patient all the way from subjective assessment, objective assessment, come to analysis, come to plan of treatment, come to goal setting, come to implementation of treatment through various means based on the root cause of the problem and the actual challenge. This is another problem. Increased work of breathing. And again, you can see the umbrella description of the problem, increased work of breathing. But increased work of breathing also can be caused by a number of factors or situations. It could be shortness of breath due to the ventilatory drive. It could be increased, respiratory function. It could be from increased use of the accessory muscles. In each of these three cases, the energy cost of the breathing function is going to be higher than normal. So all of it, the problem is increased work of breathing. But the etiological factors are different. And therefore, approach cannot be the same. approach will have to be tailored towards the root cause of the increased work of breathing. And of course, again, also, how do we identify the disease profile and history, increased, respiratory rate or respiration, altered respiratory pattern, use of accessory muscle, breathlessness, altered arterial blood gases. So as you gather all this information together and you sit down and you analyze, first of all, you will identify that the problem is increased work of breathing. Secondly, you will realize and discover the etiological factors for that particular problem. And then you set your goals. And you can set your goal using different possible outcome measures. For example, you could have assessed the magnitude of the increased work of breathing using the Borg scale of perceived exertion. And so you can set your goal based on the magnitude of the perceived breathlessness in terms of the score on that scale. If by virtue of the ailment, the score on the Borg scale is 8/10, you can say that the perceived exertion will reduce from 8/10 on the Borg scale to 6/10 over the next 3 treatment sessions. Now, another way you could also assess the goal is in terms of the respiratory rate. With increased work of breathing, there will be dyspnea, labored breathing. Respiratory rate will be higher than normal. You could either state the goal in terms of amount of reduction or proportion of reduction. And let me explain this. If the normal breathing rate, for example, is 24 breaths per minute, and in this patient, it has gone to 32, that's an increase of 8. Now, you can set a goal that says that respiratory rate will decrease from 32 to 28 over the next so number of days. What you are saying there is that you are setting the amount of reduction that should happen to the respiratory rate. But you can talk about it in terms of proportion of the alteration. Normal is supposed to be 24. It had gone on to 32. That means that it has risen by 8. You can say that Mr. Hector's work of breathing can reduce by 50% of the alteration in breathing rate. The alteration is 8 from 24 to 32. 50% of 8 is 4. So what you are saying by that statement is that his breathing rate will drop from 32 to 28. So you can use either. Another way, which is a bit subjective, not as objective as the others, is that with the increased work of breathing, some accessory muscles have been brought in to assist the diaphragm for inspiration. So you see the use of accessory muscle, involvement of the accessory muscles in the breathing. Then you can set a goal and say that there will be no visible use of accessory muscle of inspiration in the next 5 days. So you are specific because what you are looking out for is the involvement of the accessory muscle. It is measurable in that, it can easily be seen whether they are participating or they are not participating. It is relevant to the patient because that's his problem. That's what he has come to complain in the clinic. And we have fixed a time frame within which we want that goal achieved. So the goal is SMART. Now, having used these two cases to explain, okay, this is just talking about the treatment options that we can employ in achieving our goal for this patient: positioning, relaxation, breathing education. So all these are things, interventions that you can implement as physiotherapists to address the problem of the increased work of breathing. Now, I'll skip some other examples like decreased volume, the problem identification, and then the goals, the treatment options for that, then reduce exercise tolerance. Again, you can see that even though a common problem, the causes are different: reduced mobility, reduced fitness, distance mobilized. So the strategy will be based on which of them is responsible for the reduced exercise tolerance, and then how to identify, and then the goals that you can aim for, and then plans to deal with the problem and get it resolved. Thank you very much. So we have seen how we identify the problem, how we set the goal to address the problem, how we state the goal in smart ways, and how the etiological factor responsible for the listed problem dictates what specific intervention that we utilize. Any question? Okay, let me see if there is any of the questions that were submitted that is related to what we have just mentioned. None in particular, but okay, since there is no question presently, maybe I should just quickly answer some of those questions that I saw on the platform when we had that break. Somebody was asking that what is the place of the Cushing trial, in cardiorespiratory patients. Am I quoting the question correctly? Who asked the question? Hello?
Hello, sir. Good afternoon, sir.
Yes. Who asked the question?
Sir,
Are you the one that asked the question?
yes, sir. I'm the one that asked
So,
the question.
have I quoted your question correctly?
Yes, sir. Is the relevant of pushing trial in cardiorespiratory?
That is
the question.
yes. Okay. So let me answer that. You see, when we talk about the Cushing triad, it is talking about the triad of hypertension, bradycardia, and irregular respiration that happens as physiological response to increase the intracranial pressure. So it's not particularly relevant for patients with cardiorespiratory disorders, but this thing is more common in patients that have head injuries. And but because of the nature of this physiologic response to the increased intracranial pressure, hypertension, bradycardia, irregular respiration, all these symptoms are cardiorespiratory. So it will now call for cardiorespiratory intervention. But the primary problem is not a cardiorespiratory problem. Instead, it is a neurological problem. But because the manifestation is through the cardiorespiratory system, it will require cardiorespiratory intervention. Do you get me? Hello?
Hello, yes, sir. I'm listening. Yes, sir. Thank you so much, sir.
Okay.
Thank you.
Okay. So that's that question. Then there was another question. How do we carry out percussion for patients in coma? When a patient is in coma, what will indicate for the percussion? Now, rather than percussion, what will be necessary in that patient is nasopharyngeal suction. Because percussion per se is to get, sound in order to know where we have accumulation of fluid instead of air. So it's only going to, give us a sign. But if you are looking at percussion as a therapeutic intervention, it will be different from the percussion that we do over the chest wall to map out the area of cardiac dullness. Rather, it's going to be a form under that class of massage, which is clapping. Because they all come under that umbrella. Hacking, clapping, pounding, they all come under that massage classification that is referred to as tapotment, which means to strike. All the procedures that involve striking, So when you do that over the chest for a patient that has retention of fluid or whatever, it is usually when the secretion is viscid or, such that you want to dislodge it in order for it to be moved. Now, in such people, when you do it, you expect the cough reflex and expectoration. But with your patient in coma, the patient is not going to be able to cough. You will still need the suction to suck out the secretion. So why put the patient into the trouble of striking the patient while he's unconscious? You could just as well have gone to do your nasopharyngeal suction straight away.
This is my corridor now. Add suction.
Hello?
This is shared corridor and bathroom.
Okay, it's a side talk. Okay. Now, there's another question. Somebody said, what breath sound will you hear in patients that are on mechanical ventilators? Am I quoting that question correctly?
Yes, sir.
Aha, okay. Now, being on a mechanical ventilator does not necessarily impose a particular type of breath sound. When people are on the mechanical ventilator, the breath sound that we can hear can be so variable. Depending on the, underlying cause of being on the ventilator and the respiratory status of the patient. We have patients that are on the mechanical ventilator that are spontaneously breathing. We have patients that are on mechanical ventilator that are not breathing spontaneously. That's they are at different respiratory status. So the respiratory status of the patient is one of the determining factors of which breath sound you are going to meet in that patient, as well as the underlying cause. And, a good number of times, the different breath sounds you will now hear is also determined by what is going on in the chest of that patient. And in most instances, it is either diminished or absent breath sound, because the machine will have taken over the breathing process, depending on the mode of ventilation that the patient is on. We have assistor modes, we have controller modes. So it depends on the mode of ventilation that the patient is on. And then if the airway is congested, is it the large airway? Is it the smaller airway? When the smaller airways are engorged, you will hear the wheezing sound. But when the larger airways are engorged, what you will hear is ronchi. But, ronchi is hard in the larger, wheezing in the lower. But wheezing is hard during expiration. Ronchi is also hard during expiration, but in the larger airway. But when you hear the sound during inspiration, that is referred to as a stridor. The stridor is a similar sound with wheezing, but it is hard during inspiration, while wheezing is hard during expiration. That's the difference between stridor and wheezing. So the sound you will hear will depend on all these factors that I'm trying to say. And when the patient that is on mechanical ventilator is a neurological patient, especially maybe a patient that has suffered the severe head injury, because of the disturbance, or the respiratory center is located in the brainstem, So when there's severe head injury, especially when it affects the respiratory center, then you can have the Cheyne-Stokes breathing, which is a kind of periodic breathing where you have a sudden increase in the breathing rate and depth, and then reduced breathing and reduced depth, and then that is followed by a period of apnea, and then you see increase, you see fall, you see silence, such periodic breathing, the Cheyne-Stokes. You hear that in a patient on the mechanical ventilator if there is head injury because of the damage to the respiratory center. So these are the things that will influence or affect or dictate the type of breath sound that you hear on patients on a mechanical ventilator. Is there any other question they asked? I think those are the 4 questions. Yes. I think I've answered the 4 questions I saw online.
Hello, sir.
Yes.
Just want to ask one question.
Yes.
As regards to this they refer to as pressures index in terms of when that determine that has ranges between 0 to 20. They call it pulse pressure. Somehow, I don't know. Sometimes we have
yes,
some.
when we talk about pulse pressure is talking about the difference between the systolic and the diastolic.
Diastolic, and it's this. I think it's the fastest as pressure, a kind of perfusion index. I think I'm correct now. Perfusion index.
Yes.
I just want to understand what is the correlation with the unconscious patients. How do we use it to actually assess the patient's level of even subconsciousness and what have you? We're having some challenge recently in our wards. Though I'm a neurophysiotherapist,
yes,
but we're just trying to see sometimes when we co-manage with cardiopulmonary specialists, cardiopulmonary physiotherapists.
Okay.
Somehow at times we go there and literally they may not be available as at the time we are attending to the patient.
Yeah.
But we equally want to have a knowledge on how to advance the patient in order to, probably by the time we are doing our coma arousal therapy and what have you, and equally moving, doing passive movements and the likes. Somehow the perfusion index will tend to sometimes increase fluctuating. We had a patient recently that measures up to 8, but in subsequent days, we discovered that the perfusion index started reducing to the level of 0.7. So I just want to ask, what is the correlation now in other, vital signs and relating to the patient's unconscious states? How do we now use that as a measure to actually determine some other things? Is there any explanation that one can give? Thanks, sir. I appreciate your lecture. I'm really enjoying it. Thanks.
We thank God. We thank God. Now, when we talk about the perfusion index, it is a mathematical derivation, and it is to be able to know whether the various tissues of the body, especially the essential organs, are being properly perfused. Because in many of the patients that are in an altered state of consciousness, there will be a kind of cardiovascular depression, whereby the pressure values will tend to be lower than proper. Now, when we talk about these values being lower than proper, you discover that the systolic pressure is the maximum pressure during ventricular contraction, ventricular systole. The diastolic pressure is the pressure during ventricular diastole. And so, what keeps blood flowing through the system is the difference between the two. It's like when you calculate pressure gradients. For example, if we are talking about diffusion, let me talk about one case. When we talk about exchange of fluid.
Hello, sir. Please, sir.
Yes.
How about what is the interventions of the medical doctors as regards to if they are trying to perfuse a patient using drip somehow and correlating it with your explanation? I just wonder if you can
Yes,
just
what they are trying to do is to increase the volume. Remember that when we talk about blood pressure is equal to cardiac output times total peripheral resistance. So
yes, sir.
When cardiac output is stroke volume times heart rate. So in these people, the pressure is depressed. Cardiac output is lower than usual. So when they hydrate by infusing fluid, adding fluid or substituting fluid, they raise the blood volume, and that increases the stroke volume because of the increased venous return. By virtue of the increased venous return, the stroke volume is raised. That brings about an increase in cardiac output. So with the increase in cardiac output now, the systolic pressure is raised. Take, for example, if the systolic pressure was only 100 and the diastolic pressure is 80, the difference, which is the pulse pressure, is only 20. Now, in order to boost it back to about 40, that is the usual value, 120/80, they now add fluid. Based on the fluid added, systolic blood pressure is raised from 100 back towards 120. Let's say they didn't even achieve up to 120. They are able to raise it and it has become 110. 110 minus 80 is now giving them 30. A difference of 30 will permit better perfusion than a difference of only 20. So they have succeeded in enhancing perfusion. Do you get the logic?
Yeah, yes, I guess. Yes. So that's all.
So that's the thing. The only difference, because you see, as cardiorespiratory physiotherapists, we will also want a better balance. Such expansion of the fluid, we will prefer if they achieve it through blood transfusion rather than mere hydration. Because through blood transfusion, there will be red blood cells, there will be hemoglobin that will carry oxygen, so that it's not just mere perfusion, but there will actually be improved oxygenation. because oxygenation is the most important thing. If you just give ordinary fluid, it will expand the volume, but it will drop the PCV. And so it may not necessarily bring about a better oxygenation of the tissue. The only thing is that it can serve a kind of emergency situation whereby the first thing is to increase the BP so that there is perfusion pending the time, because if to transfuse blood, they might even have to go and do cross-matching of the blood and whatever. And instead of waiting for that, and then the pressure falls down below normal and life is lost, they can boost it with fluid in the first instance to maintain blood pressure, while they are now doing cross-matching and whatever. And they later continue with blood instead of ordinary fluid.
Sir, hello, sir.
Yes.
In a situation whereby we are having, because some of us, we try to monitor the SpO2 relating to the pulse rates and on the likes. Like in a situation by this, whereby the perfusion index tends to probably decrease, and the SpO2 is actually appreciated, so to say. The perfusion index is coming down. Somehow, if it's coming down, we're trying to a little bit be caution somehow. If we have the machine that is like in ICU, which we always are valuable, then whereby we look at those parameters and trying to take some caution. Somehow, if we are doing our pulsive movement, we see that some at times the perfusion index tends to decrease, and the SpO2 still maintains something relatively normal and is still okay. Even the pulse rate corresponding equally okay, but the perfusion index now tend to try to calm down. Somehow, some of us will try to say, okay, let's stop. If we are using that index to monitor some certain development of the patient, so we're trying to see, I say, okay, let's stop the PM, for example, and trying to see whether it will appreciate again, and then we now continue. So how does that? Now we're seeing that we have, let's say, for example, SpO2 is around 98%, and there.
Yes, because the difference in what these things monitor is this. SpO2 is measuring the availability of oxygen in the blood.
Yes, sir.
Perfusion index is looking at the amount of blood that is getting to vital organs. Now, when you move the limbs, that is a muscular exercise. In hemodynamics, immediately you exercise the muscle, the energy demand and therefore nutritional demand of the muscle increases. So blood will be directed to the skeletal muscles that are exercising so that there can be supply of needed energy. Immediately blood is shifted to come to supply the muscles, those organs that they are trying to perfuse will lose flow to them, because it is the blood that is supposed to flow to them that has been redirected to the muscles. That's why you see the index falling. It's just like when you eat, when after a meal, you see many people, shortly after they have just eaten, they begin to feel drowsy as if they want to sleep. Because blood is immediately shunted away from the brain to the GIT. So there is increased perfusion of the splanchnic region, splanchnic circulation. And because of the reduction in the flow to the brain, drowsiness sets in and the person wants to begin to feel sleepy. I'm sure you will have observed that when people eat, just finish
Yes,
eating.
yes. Somehow we
So
don't even want to carry exercise when they are just being fed. Somehow we want to allow them to actually have their sleep somehow. So we equally adopt that method, not to engage the patient in any exercise shortly after eating.
Yes. So it's the same principle of shunting of blood to areas where it is critically needed at the moment.
Thank you, sir.
It's a pleasure.
Yes.
Okay. So let us go to the next topic. Okay. So we come to principles of management and outcome assessment. So having seen how we identify problems, how we set our goals, how we plan what to do that will address the problem, guided by what caused the problem, the exact mechanism of the problem. When we now want to manage in implementing our treatment plan, what principles guide us? And as we implement the treatment, how do we assess the impact or the effectiveness of our intervention? That's what this presentation is all about. I've spoken about the clinical reasoning, and then we've spoken about the goals, which is to correct or to reverse the dysfunction, to reduce the rate of deterioration, to avoid the worsening of the patient's condition. Now, the goals of our intervention. We have both short-term and long-term goals that we want to achieve. When we talk about the short-term goals, we are talking about what we immediately want to achieve. But when we talk about the long-term goal, we are talking about what we eventually want to happen. And the short-term goal and the long-term goals are focused on different things. For the short-term goal, there is something that threatens life, a dysfunction, and we want to correct that dysfunction immediately. That's what the short-term goal is directed at. If the dysfunction is left unattended to, the situation can begin to deteriorate, get worse and get worse and get worse. So our short-term goal is to reduce the rate of such deterioration or decline and to avoid the situation of the patient becoming worse. Whereas, on a long-term basis, we want to make sure that the various steps in oxygen transport is enhanced in efficiency. Because the cardiorespiratory system, they work hand in hand to ensure that oxygen, is available to all tissues of the body for survival. So every step that is involved in this oxygen transport, getting blood to the lungs in sufficient amount, at a sufficient pressure head to drive the circulation, the blood getting to the respiratory membrane, exchange of gases taking place across the respiratory membrane, such that diffusion is not compromised. Because if the pressure in the pulmonary circulation should rise above normal, then the pulmonary hydrostatic pressure will rise. And that will result in extravasation of fluid into the interstitial space in the lungs. And that will increase the thickness of the respiratory membrane. And according to the Fick's principle of diffusion, if thickness is increased, diffusion rate will slow down. So, blood must get to the lungs at appropriate pressure head in sufficient quantity. And then the respiratory system, ventilation must bring in oxygen into the lungs from the atmosphere at sufficient pressure. And then oxygen diffuses into the pulmonary capillary blood, and the blood comes back through the pulmonary vein to the left atrium, and then through the left ventricle, the heart, cardiovascular system, pushes the blood out through the aorta, and then it can go to all the other parts of the body to supply oxygen. So there's a certain level of efficiency at which this system works. So on a long-term basis, we are interested in making sure that the efficiency of this system is enhanced so that life is not threatened. We are also interested in enhancing the efficiency of the various compensatory mechanisms to chronic diseases. When individuals face chronic diseases, the functioning of various systems become impaired. And when functions become impaired, nature tends to compensate to make sure that there is continuity of life. So these compensatory mechanisms, we want to enhance them so that whatever deficit the chronic disease has brought about, the compensatory mechanism can supply it. And we want to optimize oxygen transport capacity to sustain maximum functional activity. So those are the things that the long-term goals will address. Now, there is also the dimension of secondary prevention. Because when we talk about prevention, there are 3 levels of prevention. There's primary prevention, there's secondary prevention, there is tertiary prevention. So now, this secondary prevention here is to prevent further cardiopulmonary dysfunction. And when the cardiopulmonary system is prevented from, being damaged more, then multi-system organ function can be preserved. Then to prevent further restricted movement, because we know that if movement is restricted, there will be deconditioning. So we don't want deconditioning to compromise the efficiency of oxygen transport and delivery. Then there is patient education on movement and safety mobility, so that, according to the slogan of World Physiotherapy, we move. So movement must be sustained. Sedentariness must be avoided by all means. And while we are trying to move, safety is very, very important. Now, when treatment intervention is implemented, we are interested in assessing the efficacy or the impact. So in cardiorespiratory physiotherapy practice, outcome measurement is an essential part of the practice. Like my brother that just asked the question, and we were giving explanation. You see the practice in that place, how things are being monitored. The perfusion, the oxygen saturation, and everything. So it is as we obtain those measures and we have those values that we know how to modify what we need to modify. So outcome measurement is an essential part of cardiopulmonary physiotherapy practice. And when we, utilize outcome measures, we can establish a baseline of patient's condition. It can guide, effective management. It can guide our plan. It can guide our line of intervention. It can guide our management. It can guide, even the modification that we need to bring into what we are doing. And then, on the long run, it can document the effectiveness of the treatment, whether the treatment had been effective or not. And to be effective is to produce a sufficient magnitude of the desired change. And when we talk about outcome assessment, there are certain things that must be considered. The first thing is the choice of outcome measure. What outcome measure do you choose? Take, for example, let me cite the question of my brother just now. He was interested. Okay, which one, what do we follow? What other can we rely on? Is it the perfusion index? Is it the saturation SpO2? Now, which brings us to the issue of choice, where you have the option of measures or tools to use. How do you decide which one of the available options to use? So you should choose the most reliable and inexpensive. And I want us to observe the sequence. Reliability is a bigger consideration than cost. A good number of times, people compromise reliability on the platform of cost, and they place lives at risk. The measure they ought to use, they say, oh, it's very expensive. Let's just use something that is not very expensive and whatever. And then they use something that is less expensive and which is less reliable. And so it is giving them values that are not too helpful because those values are not very reliable. So the first thing is to look for which one is more reliable. In other words, there is reproducibility in the values that it provides. If the reproducibility is poor, then we cannot rely on the value that it gives us. It will just be like a tool that has a high level of false positive. False positive. In other words, it can be telling us things are good when they are not really good. And then when you now have two, let's say you now have two options, A and B, that are equally reliable, you can now consider cost. Which of the two is cheaper in order to reduce the cost of care? But in the first instance, you have considered reliability. That's one of the principles that guide our choice of outcome measure. Then we avoid outcome measures, that will be invariance to action or treatment on other problems. In other words, the patient has, let's limit it to two problems, problem X and problem Y. Now, for problem Y, there is an action that is needed to remedy it. Now, you are now using an outcome measure to assess change in X. And the application or utilization of that outcome measure compromises Y. You must avoid such. Another thing to consider is this variable concerning the patient's problem. What is the critical value that it gets to that is a warning signal whereby I must either take action or I must invite somebody else? Take, for example, my brother was talking about the SpO2, which you can measure with the pulse oximeter. normal value is anything from 95% towards 98 and everything. In certain situations where the patient gets a bit desaturated, we talk about desaturation, especially in ICU patients. It can come to below 90. Immediately, it begins to approach a value of 80. It's a danger sign. The therapist, for example, if the therapist is managing the patient at that instance and he observes that drop, he must stop what he is doing. If for what he is doing, they have had to disconnect any tube from the patient, the tube must be immediately reconnected so that there can be restoration of the saturation. If no tube was disconnected and that is observed, they must immediately call the attention of the anesthetist. That's talking about the threshold for taking action or notifying someone. It must be clearly stated. And it must be carefully observed. Now, in terms of outcome assessment, still, we don't just collect data because we for fancy. People collect data that eventually they are not going to make use of. Sometimes the one who has collected the data does not even have the capacity to utilize it by virtue of his current level of skill, knowledge, or expertise. So that is being wasteful. We don't collect data beyond what is necessary and what we are capable of using in terms of interpretation and acting on it. Now, we must be precise about which outcome we want to use to assess our results. We must know the criteria that indicate success and the criteria that indicates failure. We must be clear about how often do we measure. Let me use this as an example. Some people, you remember that in exercise physiology, we talk about acute responses to exercises and adaptation, chronic adaptation to training. And so we know that when people engage in training, the body adapts. And when the body adapts, the level they have attained onto remains for a long time, only to be lost if that training or that action is stopped for a protracted period of time. Now, let us imagine that in terms of maximal oxygen uptake in response to aerobic exercise training, literature says that if you engage in this training protocol, it takes about 6 weeks before appreciable difference can be made in the fitness status of people. Somebody now wants to do a research work on the effect of that training protocol on so parameter of individuals, age, and so. And he's coming up with a 12-week training program. And we always say that in order not to lose data, don't just measure at the beginning and at the end. Find a convenient point, even within the interval, to also measure. Now, literature says it takes average of 6 weeks for any appreciable change to happen. This person, in trying to assess, now decide to measure at beginning, which is 0, at 4 weeks, and then at 8 weeks, and then at 12 weeks. Thinking that, oh, I just broke the 12 weeks into 3 parts for 4 weeks. Now, whatever data he is collecting at week 4 is a wasted effort. Because literature have already told you that before you can see any appreciable change, people must have continued on that program for 6 weeks. So what change do you think the data you are collecting at week 4 will give you? So it is meaninless to go at week 4 and say you are collecting any data. So the same way, when we are managing patients and we are having repeated measures, how often do we measure? Our practice must be evidence-based. That line of intervention, for how long should it be implemented for clinically significant difference to be recorded? You must have at least that spacing between your measurement for it to be meaningful. Now, exercise assessment, we can have various forms. We have exercise stress testing. We have protocols that are maximum protocols. We have sub-maximum protocols. As a matter of safety, we do not encourage protocols that are maximum. Rather, submaximal protocols are preferred, especially in patients with cardiorespiratory disorders, because we don't want complications on our hands. Then we have means by which we evaluate activity and endurance, like the walk tests, 6-minute walk test, 12-minute walk test. All these can be used to assess exercise capacity and exercise tolerance. Then, while patients are undergoing treatment, clinical monitoring is very, very important. Again, let me refer back to the colleague that asked that question, especially about the patients in the ICU. You can see the practice in that setting that even as you are applying your treatment, you have your eyes on the monitor to see what is happening to the perfusion index, to see what is happening to the SpO2, even as you are carrying out your treatment, so that you know what to do at what time. And so there are various parameters that we monitor clinically, even as we administer our intervention. The heart rate, both the resting rate as well as, under stress, the rhythm of the heart, the blood pressure, both resting and exertion, the respiratory response to exercise, the level of perceived exertion, the exercise capacity of the individual. All these variables must be regularly monitored. And of course, apart from measuring these cardiovascular and respiratory variables, there are other assessment tools that are used along, because there are other things in the body that can influence the cardiorespiratory health. For example, body composition, the degree of adiposity, that is the percentage body fat, can influence the cardiovascular system. There's a relationship between obesity and hypertension. There is also a relationship between obesity and chronic obstructive pulmonary disorders. So there are other parameters that we assess in cardiorespiratory physiotherapy practice. We also assess the respiratory muscle strength as well as respiratory muscle endurance. We also have pen and paper instruments by which we also collect some semi-objective information. Some assess health and fitness, some assess quality of life. We also have measures that assess general health, like the short form 36 and the SIP, sickness impact profile. Those ones appear to be generic, but we also have instruments that are disease specific. Some are disease specific for respiratory disorders. Some are disease specific for cardiovascular disorders. On this slide, we have 3 that are respiratory disease specific instruments. The most popular of these 3 is the St. George's Respiratory Questionnaire, the SGRQ. And then we can also see the cardiovascular disease specific questionnaires. The important thing we are trying to drive home is that outcome must be regularly assessed and monitored. Thank you very much. Again, any question? We've looked at the principles that govern our patient management, as well as outcome assessment how we choose which one to use. So, any question?
Hello, sir.
Yes, sir.
You were talking of about costs and
reliability.
Reliability, yes, of choice. Does it always, for example, if we are actually monitored to take to choose a particular outcome measure above another, doesn't always in terms of costs per se or in terms of efficiency?
Reliability comes first. And reliability has to do with the efficiency and accuracy of the data you are collecting. That's why reliability is superior to cost.
Okay, superior to costs.
Yes. It is when you now have two options that are equally reliable, but one is cheaper than the other, that you now go for the cheaper one because you want to reduce cost of care.
Sorry, I'm sorry, sir. It could be a little bit a bit of a digression, but then it's
no
still
problem.
in tandem with it should be still in tandem with the cardiopulmonary of a team. But
no
if, for
problem
example, we want to have a choice. And for example, we from the neuro end, if we are, let's say, assuming we want to just start a kind of progressive rehabilitation of a particular patient, and the first time we are trying to take the patient to standing position, standing reeducation for the first time, having spent some times online and probably
in line position.
And now we want to advance to a standing position, and we now discover that, okay, in standing this patient, having put all this in place, we are now using our pulse oximeter to now monitor.
Well,
you are now using our pulse oximeter to monitor. Yes, we are now using our pulse
oximeter will not give you the true result. Oh.
Yes, will not give us true, but then for some certain challenges that we may want to experience, the oxygen saturation may be at a normal value, and then
the patient is dizzy because it is the perfusion of the brain that is important.
Yes, and the pulse rate too still give us something relatively around, let's say, around 70 or 75 beats per minute, and we are not taking the patient with that value. We have oxygen saturation to be let's say 98%, still okay. Then in a bit of taking that patient up, the SpO2 appears to be still maintain that value, but the pulse rate is now coming down. Do we choose the SpO2 to be the priority to consider, or the pulse rate that is coming down?
Both are not specific for what you are testing. The SpO2 and the this thing, they are not specific for what you are testing. You see, there is a protocol for taking your patient to a direct position after a protracted recumbency, and that is through gradual tilting. Gradual tilting. You tilt the bed gradually. In other words, you don't change. Pardon? Hello?
Sir, we are at the stage of standing. We are at the stage of standing. We have gone beyond sitting of the bed now.
What protocol did you follow in tilting the bed? How did you go about it?
So we have a protocol of 30-degree tilting, then 60, then so those
For
are
how long? For how long? For how many days did you put him through?
Somehow if we in a couple of, let's say 2-3, because a client is 60, 90. So, and the patient seems to have been stable at 90, for example. We may want to advance in.
So 90, what do you mean by 90? What do you mean by 90?
90 degree hip.
90-degree hip flexion is nothing. 90-degree hip flexion is nothing. You see, that is saying that you put the patient in long sitting position. Am I talking? Hello? Hello?
We can hear you, sir.
Yes, you know, what he has described. What he has described is putting the patient in long sitting position on the bed, where the lower limbs are flat on the bed, and the patient had been propped up with pillow to a 90 degrees angle at the hip joint. That's the 90 degrees he's talking about. It's a different ball game from standing. Reason being this, as at that point in time, the surface of the bed is the supporting surface. If you measure the height of the heart from the surface of the bed, it will be from the chest to the surface of the bed. That is the height. And then the height of the head from the heart is constant. By the time you take this patient into standing, from his hip to his ankle, we now stand on the ground. The ground becomes the supporting surface. Look at the height of the heart to the ground. Look at how much effect of gravity we push blood down to the feet rather than the head, and compromise cranial blood flow. So that's not it at all. When I'm talking about you tilting the patient, it involves the lower limb also gradually going down. So, and the protocol is that you tilt the entire body of the patient gradually by tilting the entire bed. And you do it little angle at a time, and you keep the patient in that posture. Take, for example, if you tilt the bed by raising the upper legs, the legs towards the head of the bed, you put maybe a 4 inches block below the feet. That will tilt the bed to a certain angle. You can measure that angle and record it. You allow the patient to be in that position throughout the day for a number of days. After then, you increase the height to which you have tilted the bed, and the patient remains in that position throughout the day for a few number of days, maybe 2 or 3 days. And you keep on increasing the angle. At a point in time, you now lower the legs of the patient at the edge of the bed while he is still seated on the bed. And he will do that for protracted period of time, a few number of times in a day, for a few days, and assess the stability before you get the patient on his feet. Just propping the patient up in long sitting has not prepared that patient for orthostatic hypotension. The risk of hypostatic, hypotension, orthostatic hypotension is very high. Is that okay? Ooh. It's like, do I still have the people with me? Oh, there are some.
Yeah, with you, sir.
Okay. Oh, thank you.
Yes, sir, we are with you.
Okay. Okay. So the protocol, they should follow standardized protocol and not stand that patient after just propping up in bed. Okay, there is a question here. In the case of an unconscious patient in the ICU who has retention of secretions, is it the place of a physiotherapist to carry out suctioning after manual therapy techniques such as percussion have been done? Now, that's a question bordering on scope of practice. Scope of practice is something that is variable from one environment to the other. In some environments, nasopharyngeal suction is within the scope of practice of physiotherapy. But presently in Nigeria, it is not in the scope of practice of the physiotherapist. And every professional must remain within the scope of practice to avoid unnecessary litigation. So presently, it is the nurse that will do the nasopharyngeal suction in Nigeria. That's not to say that if you travel to other countries where it becomes part of your scope, you are going to be prevented from doing it. You will have to do it. So it's good that you learn it. This question says, is it advisable to carry out a percussion as well as shaking and vibration technique for a patient who is currently undergoing dialysis, has a central line in place, and is having difficulty with secretions? The dialysis has nothing to do with your whatever. The dialysis is simply a kind of purification process, a filtration, when you filter something to remove the dirt or the unwanted particles or whatever from a solution. So it doesn't stop you from carrying out your chest physiotherapy. The only thing is that we know that even for chest physiotherapy, there are contraindications, and hemodynamic stability is one of it. So if that patient is not hemodynamically stable, then your procedure will be contraindicated. The contraindication is not because of the dialysis, but rather because of the hemodynamic instability. Now, somebody says, can we perform airway clearance techniques on a patient with acute pulmonary embolism who has only been on medical therapy? Okay. Now, the airway clearance technique is an activity in the airway. Embolism is an issue within blood vessel. So they are different passageways entirely. So it doesn't preclude you from carrying out your airway clearance. It's like if you have two parallel pipes running through your room. One carries palm oil. The other one carries water. And there is an issue with the one carrying palm oil. And you say, because the one carrying palm oil has issue, can I work on the pipe that carries water? Of course you can, because it's not the same pipe. Okay, somebody is asking question. What is this procedure called? This explanation on body measurement. Well, the person has not actually indicated what body measurement is being taken. So it's difficult to answer that question. You know, when talking about body measurement, are you measuring circumference? Are you measuring girth? Are you measuring length? Olufunmilola is raising the hand. Please, you have the floor. Unmute yourself and ask your question.
Yes, sir. Thank you so much for the
After
wonderful
you, Akim
presentation.
Saliu is also raising the hand, so you speak after Olufunmilola. Yes.
Okay, all right, sir. So I was the one who asked the question about the patient with dialysis. So my concern, sir, was more because he has a central line that has been placed, a tube, that has been placed very close to the chest and near the heart, that is used for the dialysis. So my fear is that in trying to perform this technique, the fear of dislodging anything or causing any harm to the patient, I think that's where my fear and my reluctance came
Yes,
about.
I'm
And that
sure
was
that
why I asked
they will
the
have used
question.
some plaster or some taping to secure the line, to strap down the line.
Yes, sir.
Did they use
have.
any plaster? You know,
yes,
zinc oxide plaster to hold the line firmly over the skin?
Yes, that has been done.
So if that has been done, now, what is the actual talent for which you want to do the airway clearance?
Okay, sir. The patient has chronic kidney disease, and he also has a history of sleep apnea and asthma. Though currently he's being treated for the chronic kidney disease, and he complains of he has a lot of secretions. Whenever he's, breathing, you can actually hear it.
Yes.
So most of the time he has a cup beside him where he's able to clear. But I'm concerned because he's not having effective clearance of those secretions, and it's affecting his breathing pattern. His breathing is still a little irregular, and the rate is about 28.
What I will advise you to do
is
get online, read something about facilitated cough technique.
Okay, sir.
Facilitated cough technique. And teach the patient.
Okay.
Facilitated cough technique.
All right. Thank you so much, sir.
Yes. Okay. Yes, Akim.
All right, sir. Thank you very much for the wonderful. Thank you very much for the wonderful presentation, sir. So I want to make clarification about the issue of pulmonary embolism. So I want to know, sir, at what stage is physiotherapy actually indicated? Is it at acute phase when the patient is currently being brought to the hospital? Because what I used to know is that issue like pulmonary embolism is a red flag that needs immediate medical attention. So if physiotherapy is not indicated, is it at acute phase when the patient is just brought to the clinic or after the patient has been stabilized?
Yes. Now, talking about the phase where physiotherapy will be indicated is a function of the medical stability of the patient. In that, with the embolism, what were the symptoms that the patient was presenting when he was rushed to the hospital? What is the current state of the patient? And what are the problems that require physiotherapy intervention? If the physician that is managing looks and assesses and realizes that the patient needs physiotherapy intervention, that's already the license for the therapist to know that his expertise is needed. So there's no need to be afraid of anything in that instance. In that, when we talk about the embolism, we are actually talking about a foreign material in the pulmonary vessel. It is inside the blood vessel. And the foreign material could be air, could be fat. If the patient has had a fracture recently, some fat from the fractured bone. If a vessel got pierced around that place, and some of the fat in bone enters into the vessel through that's fat embolism. It could be air embolism, it could be fat embolism, or if it is a patient that has had deep vein thrombosis and the DVT got fragmented and dislodged, then it is a clot that will have become an embolus. Now, it means that embolus is circulating freely in the pulmonary vessel. So, what is the associated problem that requires physiotherapy? Because it is not the embolism that is requiring physiotherapy now. And that's what we've been talking about, the problem-oriented approach to treatment. Because we do not treat because of the diagnosis. We treat because of a problem. In other words, there's a problem the patient has. Physiotherapy is capable of alleviating that problem. That's the indication for physiotherapy. So what exactly is the patient presenting with that is amenable to physiotherapy? Has the patient been referred? Has the patient been referred for physiotherapy?
Yes.
So what was the relevant medical history that the physician wrote when he was referring? Or for what did he call the attention of physiotherapists for?
They just wrote referral for acute pulmonary embolism. Just this patient needs okay, the patient has persistent coughing and they seek immediate physiotherapy intervention. So that's the reason why.
So the problem of the patient now is persistent cough. Now, the next thing to find out is what is the exact mechanism behind this persistent cough. Just like when we are talking about increased work of breathing, there could be 3 possible mechanisms causing the increased work of breathing. It is when we identify which of the mechanism that we will know how best to intervene in that increased work of breathing. So this persistent cough in this patient, what is causing the cough? What is causing the cough? Is he amenable to physiotherapy? That's what we need to find out. So you can only find that out when you pick up the referral and you go to the patient and you do a thorough history and assessment. For such a patient, it might even be a cough that is triggered by posture. And all you need to do is postural intervention. You advise on certain postures that will inhibit the cough reflex. And, by the time the cough is suppressed, they will think that you have performed the magic. Yes. Olufumilola is still raising the hand. Is it that you have not lowered it after we spoke?
I've not lowered it, sir. I'll lower it, sir.
Okay, is it a fresh thing?
No, sir.
Okay. Yes, the person, Emmanuel Chukuneke, you are talking about the issue of body measurement. What's the nature of the measurement? So that we can address the matter. Emmanuel. Okay. It's not. Okay. Yes. I'm receiving a gladdening news here. Abdullahi Fortis. Are you there? Abdullahi Fortis.
I'm here, sir.
Yes, I just read your message now. Which establishment is that? I mean your place of work. At which hospital are you working? Hello. Hey.
I'm in Kano to KTH.
KTH.
Hello. Yes, sir.
That's Kano. Oh,
yes,
that's
sir.
Beautiful. I'm glad to hear that. You are free to carry out the procedure there. You see, it is clearly within the scope of practice of physiotherapy. But what happens is that in Nigeria, because in the past, we do not have people who are confident in the field of cardiopulmonary physiotherapy. So even some physiotherapists, as at that time, many were even afraid to touch patients in the ICU. So by virtue of that, and because nature will never accommodate vacuum, the nurses were doing this thing, And so the nurses had retained it as if it is only them that have it within their scope of practice. And so if you now try to come there and whatever, there's this kind of territorial protection. Why do you want to do this? Why are you doing this? It's not your duty, it's our this thing and whatever. That has been the attitude in the Nigerian health climate. But I'm glad that nobody is restricting you there, because it is actually within your scope of practice.
Thank you.
Thank you very much. Yeah.
Hello, sir.
Yes, hello.
Yes, furthermore, we even lectured them on critical care physiotherapy.
Aha. I mean, that's beautiful.
Sensitize them to encourage every establishment to invite physiotherapy and possibly have a close ICU system where physiotherapy office will be located inside the ICU.
Yes, definitely. In fact, that's the ideal practice. That's the ideal practice. Just like, you have an anesthetist that is posted to that place. That's how there should also be physiotherapists that are on rotation in the place. That's how it ought to be. Yes, so that was lecture 5. Okay. Dr. Jibrin.
Sir.
How much time do we have left? Because it's like there are still 2 lectures. How much time do we have left?
I think we are supposed to close by 5.
Yes. Okay. Okay. Let me see, of the 2 lectures that are left, which one can I take within the short period that we have? Okay. What I'm going to do is that I'll jump to the last lecture, which is cardiac rehabilitation and pulmonary rehabilitation.
Okay, sir. Okay, sir.
Yes. Okay. I think I should be able to run through that in 30 minutes. Okay. Yes. Can we see my screen?
Yes.
Okay. So, I've been informed that we have less than 30 minutes left, because we are supposed to be rounding up by 5 o'clock, and this is 4:37. So, let me see how I can run through this topic in 30 minutes. cardiac rehabilitation and pulmonary rehabilitation. Now, I broke the topic into two parts. The first part on cardiac rehabilitation, and then the second part on pulmonary rehabilitation. Talking about cardiac rehabilitation, most people are very familiar with that. It is the aspect of pulmonary rehabilitation that some have not been too familiar with because it's not as popular as cardiac rehabilitation. And here we have a kind of definition for cardiac rehabilitation, that it is a comprehensive, medically supervised program. And it is aimed at improving several dimensions of individuals' well-being. And when we are talking about these dimensions, we are talking about the physical, the emotional, and the social dimensions of people's well-being. And we are talking about people who have heart disease or they are recovering from cardiac events. So we put up a program, to improve their well-being in a holistic manner. When we implement it, there's a purpose in view. And it is to enhance cardiovascular fitness, to reduce the risk of future cardiac events, to improve quality of life, to promote psychological well-being, and to support long-term lifestyle changes. Now, the reason why I have brought this out is that these are like goals to achieve. And therefore, in coming up with the program must be designed to achieve them. And therefore, when you implement the program, there's the need for you to put in place outcome measures that can confirm that these goals have been achieved. So in other words, when we are talking about outcome tools or outcome measures to use in cardiac rehabilitation, this list already gives us the kind of outcome measures that we must look out for, that we must utilize when we are carrying out cardiac rehabilitation. Because our practice must be outcome-based. It is our practice is outcome-based, and we actually take the measurement and we report the measurement that will be contributing to future evidence-based practice. Now, it means that in conducting our cardiac rehabilitation programs, we must be armed with outcome tools that can assess cardiovascular fitness. We must have pen and paper instruments that can chart and monitor future cardiac events in those that we have had to handle, either in terms of hospital admissions and things like that. We must have instruments that can assess their quality of life. We must have instruments that can assess their psychological well-being and their long-term lifestyle changes. And that's when we'll be able to say that we have accomplished all we set out to achieve. Now, it has been recorded in literature that when people are taken through cardiac rehabilitation, there are certain benefits that accrue to them. And that's what this slide is presenting here. That their cardiac function experiences improvement in terms of efficiency, in terms of heart rate recovery. That mortality is reduced. And that is assessed in terms of the risk of recurrent cardiac events and in terms of actual mortality. That's talking about longevity after the program. In terms of improved quality of life, which can be assessed through physical fitness, emotional well-being, and overall life satisfaction. And that the healthcare cost that these people face is reduced because they have reduced hospital readmissions as well as reduced healthcare utilization. So what they spend on healthcare drops. Now, having seen the aim of cardiac rehabilitation, what is the role of physiotherapy in this program? Because it is a program that is multidisciplinary in nature. So, the physiotherapist, as a member of the multidisciplinary team, what does it take to the table to offer? Exercise prescription and patient education. Exercise prescription in the sense that there is no generic exercise protocol for everybody. Rather, exercise programs are tailored to the individual needs of the patient. And the physiotherapist is an expert in exercise prescription. And the physiotherapist, the second medicine of physiotherapy is education. The first medicine is exercise. So the physiotherapist can provide education on safe physical activity by these people in order to avoid sedentary lifestyle. And he can also inform them and educate them on how to recognize symptoms of cardiac distress so that they can nip things at the bud. At the slightest hint of it, they can seek for intervention. So, physiotherapists monitor and they assess. And this is done continuously. They also support and motivate. They encourage the patients to adhere to the rehabilitation program. And they motivate the patients by addressing psychological concerns that they may have. Cardiac rehabilitation is a program that consists of 3 phases: phase 1, phase 2, and phase 3. Phase 1 is the inpatient rehabilitation component, and it focuses on early mobilization, education on cardiac risk factors, and then the commencement or initiation of lifestyle changes. That's what is focused on during this phase of cardiac rehabilitation. And when you look at this, you discover that the physiotherapist has a lot to offer. And in fact, in the first one, which is early mobilization, that is his major specialty. Because the other 2 areas, there are others that could also offer education. And there are others that can also offer lifestyle changes guidance. But as for early mobilization, it is essentially the scope of practice of the physiotherapist. Now, this phase is usually undertaken in the hospital setting. And the various activities that the physiotherapist can bring in at this phase include bedside exercises, basic mobility training, education on energy conservation, and monitoring of vital signs as the patient engages in the various activities that are listed. The second phase, which is outpatient, but the early part. The third phase is also outpatient or community-based, and it is at the latter part. Here, we engage them in supervised exercise training, education continues, and risk factor modification. It is carried out in the outpatient clinic or in a cardiac rehabilitation center, unlike the phase one, which is hospital-based. Activities that are incorporated in this phase include aerobic exercises, which may be in form of walking, cycling, and so on and so forth. Then resistance training, continuous monitoring of the vital signs again, and psychosocial support. The third phase is the maintenance and long-term rehabilitation, where exercise continues and then the patient is trained on independent self-monitoring and is encouraged to maintain the lifestyle changes that have been adopted. Again, it takes place in the community setting or in, as home-based programs. And the activities that are incorporated into this phase are listed: regular physical activity, ongoing support groups, for mutual encouragement, follow-up assessment to ensure long-term adherence to the rehabilitation plan. As beneficial as cardiac rehabilitation has been reported to be, issues that must be considered in its implementation are shown by this slide. Patient adherence. Because it's a relatively long-term program, the tendency for participants to fall out is always there. And so, what to be done to ensure that the patients adhere to the program and continues is very important. Then the accessibility to the facilities, whether the home program or the cardiac rehabilitation center and whatever, accessibility must be promoted. Individualization is important so that program is tailor-made for each individual. And of course, psychological considerations must not be left out because of the possibility of depression and other psychological affectations of the people. Now, for pulmonary rehabilitation, it is also a multidisciplinary program, and it is aimed at optimizing the physical, and the mental status of patients with chronic respiratory diseases. And the components are exercise training, education, and behavioral changes, similar to the components of cardiac rehabilitation. And the aim is to improve overall lung function and the quality of life. Now, Talking about the goals of pulmonary rehabilitation, we want to alleviate the symptoms, we want to improve exercise tolerance and physical activity levels, we want to enhance the patient's understanding of the condition, we want to promote independence and self-management, we want to reduce the frequency of acute exacerbations. And of course, the components are listed here. Each component addresses different aspects of the patient's needs. Talking about exercise training, it includes aerobic, strength training, as well as breathing exercises. In terms of education, the patients are educated on how to manage the condition, various things that they will need to do, various things they will need to avoid. They are educated on the nature of the medications, the effect, and the need to be consistent in using the medications. And of course, nutritional guidance in terms of balanced diet and healthy nutrition. They are also given psychosocial support, because of certain emotional and psychological challenges that coexist with the respiratory disorder. The availability of support groups provides a platform for one patient to motivate and encourage the other as they share their experiences with one another. Pulmonary rehabilitation has also been reported to offer a lot of benefits for participants, in terms of reduction in the symptoms that they experience, in terms of improvement of their exercise capacity, as well as the quality of life. Other benefits include decreased hospital admissions, as well as enhanced survival rates. What does the physiotherapist have to offer in this program? Quite extensive. They are involved in exercise prescription, as well as patient education. And like we said, that programs should be tailor-made for the individuals. Physiotherapists design and they supervise individualized exercise programs. And each person's program caters for the specific need and, considers or takes into consideration the individual limitations of that particular patient. And the physiotherapist is involved in monitoring and assessing the patient as the program goes on. They also offer support and motivation to the patients. In spite of the benefits, also again, the concerns are similar as for cardiac rehabilitation in terms of adherence to program, accessibility to facilities, individualization of the program, and psychological issues or concerns. So, again, that brings me to the end of this. So those are the involvement of the physiotherapist in cardiac rehabilitation and pulmonary rehabilitation. And in the exercise prescription, all the principles that guide exercise prescription must be followed. And I want to recommend this article for every one of us. A clinical guide for assessment and prescription of exercise and physical activity in cardiac rehabilitation, a CSANZ position statement, authored by Vadicchio et al., 2023. It is published in Heart, Lung, and Circulation Journal, and it is freely downloadable. So you can download it and study it. It is very, very helpful. Thank you very much. Any question?
Thank you, sir, for the. Please, can you repeat the article again, please, sir?
Okay, the article.
Yes, sir.
A clinical guide for assessment and prescription of exercise and physical activity in cardiac rehabilitation.
By who, sir? Yeah, I said, sir, by who? You mentioned the name now, something at all. Sir, the name of the author. The name of the author.
Vadicchio et al., 2023. Vadicchio, VERDICCHIO. Vadicchio et al., 2023.
All right, thank you, sir. I got that.
It's a pleasure. So, Dr. Jibrin, over to you.
Okay, sir. Thank you so much, sir, for the presentation. In the absence of any other questions, I want to thank sir for this in-depth presentation, and also thank all the participants for the participation. Wishing to see you some other time. Thank you so much, and good day.
Thank you.
Yes.
Thank you.
Thank you, sir.
It's my pleasure. Stay
Thank
blessed.
you, sir.
Thank you. It's my pleasure. Stay blessed.
Thank you so much, sir.
Thank you. Keep the flag flying.
So, sir, thank you so much.
Yes, thank
we
you. I
appreciate
appreciate you all.
you.
Yeah.
Thank you for sharing knowledge.
Thank you very much. It's my pleasure.
Thank you so much, sir.
Oh, we thank God. It's my pleasure.
Thank you very, very much, sir. I really appreciate this very educative lecture. So it's really, really helpful. Thank you.
We thank God.
Thank you very much, sir. You have really made cardiopulmonary very, very interesting. I really enjoyed it, sir. Thank you.
We thank God. Appreciate you.
Thank you very, very much.
Okay, bye.
All right, sir. Bye. Have a wonderful day, sir.
Thank you very, very much, sir.
Thank you,
very
sir.
much, sir.
Good evening, sir. This is Dr. Davis from FMC Abeokuta. We'll be looking forward to when that workshop will be organized that you talked about.
Excuse me, please. Excuse me, please. Does anyone get the name of the recommended book that was prescribed by the doctor, please?
If you didn't get it, you will get it in the recording. When we send you the recording, or you will get everything there. The recording.
Don't worry, I will paste it now. I'll paste it now.
Thank you.
Let me
Thank
copy
you.
and paste.
Okay, the recording will be sent to our mail for sir. The recording will it be sent to our mail or any other platform?
It will be sent to the WhatsApp group for the workshop.
All right.
Yes.
All right. Thank you very much, sir.
What of the video? What of the video, sir?
The
video, for the whole workshop, there are some parts that we did not get.
Yes, that's what we mean by the recording. It will be sent
Okay, the recording.
Yes.
Okay.
Yes.
Okay, we'll be expecting it.
So please, Dr. Jubril, I want to ask, can we expect, is it certificate or any other useful material concerning this lecture in our mail? Should we be
You should expect certificates.
All right. Thank you, sir.
Yes.
Thank you, sir.
Thank you.